Okay, so you see my presentation, just confirm.
Yes.
Perfect. Okay, so let's get started. So today we're going to talk about aortic dissection and the use of POCUS to actually diagnose aortic dissection. Let me just make sure that it's actually moving forward. Yeah, so no conflict of interest to declare for this presentation. And in terms of objectives, what I want us to do, it's pretty simple. I want to review briefly the evidence supporting the use of POCUS for aortic dissection, but most importantly, describe a practical approach that we can all integrate in or a POCUS, so a bit of an algorithm to help us diagnose aortic dissection. So something that's practical and feasible that you can actually use at the bedside. So let's talk about aortic dissection. Aortic dissection, honestly, you should be considering it at the same level as a STEMI or as a stroke, because the mortality is incredible. So for undiagnosed ascending aortic dissection, there's a 1-2% mortality per hour. So time is really of essence. And at 48 hours, most of the patients will be dead by the time they actually get the diagnosis. So it's extremely important. It's a very time-sensitive condition that we should be trying to increase the time to diagnosis, honestly, in the emergency room. How can POCUS help us do that? Well, the evidence for POCUS in aortic dissection is actually not very good, and it's actually very old. So that's actually the typical thing that you will get presented whenever you ask, so what's the test characteristic of transthoracic echo or cardiac POCUS for aortic dissection? So here, this is the typical thing that you will be told. So it's actually not that good. It's not perfect, but it's not too bad. And this, though, is derived from literature that was done in the 80s. So there's a little asterisk next to TTE. All of these studies, they've been done like years ago. I wasn't even born when most of these studies were done. Most of them were actually done by cardiologists. So they have an extra level of training to look at the aortic root. And also they're looking at different things. So to be honest, I'm not looking at ulcers or hematoma or my POCUS machine in the emergency department when I'm looking at our other types of signs that we're going to discuss in a second. And also the test characteristic of TTE, they're not too bad because they're looking at the ascending aorta. For the ascending aorta, actually the test characteristics are pretty bad. All that to say that the evidence is pretty bad, actually, for transthoracic echo, but then we know the limitations of it because these are old studies. Now we have newer machines, but we also have better training in the emergency department. Is there some literature that can help us actually use POCUS? Actually, more and more. So most recent studies I'm going to present to you that are related to emergency department are actually encouraging. This is a very small retrospective study with 31 patients where they realized that the use of POCUS for aortic dissection was leading to a way faster diagnosis when you were using POCUS. You were less likely to make a diagnostic error. Like everybody who had the dissection was actually recognized as a dissection once you use POCUS. A way faster disposition time to treatment and time to disposition to go to the OR, and also a significant decrease in mortality. Okay, we have to take this with a grain of salt because this was actually a retrospective study. So this is all it's not something that we can actually say, okay, it's perfect. It's really, sorry, there's a phone call. This is another interesting study. So here what they were, it's actually a bigger study, a prospective one, where they were evaluating all those patients with a very high suspicion of an aortic dissection. So they had close to 300 patients and they realized that it was actually pretty good. The problem is when someone comes in with a typical presentation, so severe chest pain radiating to the back with a pulse deficit, well, it's obvious. I don't need POCUS to recognize that this is a dissection. So I would say that the study was not really helping me, but actually using POCUS, you really get the confirmation faster because you really have it at the bedside, while most of those patients that were going to CT, there was at least a delay of an hour because by the time you get the CT read, it was actually a little bit longer. But of course, because of the presentation of those patients, there was no impact on time to advance imaging or mortality or treatment. And then, you know the aortic dissection detector risk score, they were actually trying to see if the use of POCUS and plus or minus the ADD score, risk score, was helpful in diagnosing aortic dissection in the emergency department. Unfortunately, with this study, again, it cannot really be used as a rule-in, as a rule-out tool. So, okay, there's not much literature recently that can help us, but what I'm going to tell you is that for those hemodynamically unstable patients, POCUS has an excellent sensitivity and specificity for dissection of the ascending aorta. So one of the studies that I just presented you, there was a subset of patients that were hemodynamically unstable. And in all of them, they actually were able to find, so they were able to rule in or rule out dissection. So it would be very interesting to, if ever there's a resident interested, to see for those hemodynamically unstable patients, if we use the algorithm I'm presenting you today, I'm pretty sure we will have very good test characteristics. So think about it for the unstable patient, but also think about it because if you do find something that suggests a dissection, you will have a rapid diagnosis, you will have expedited treatment, surgical consultation, you might get advanced imaging faster than you would have if ever you didn't use POCUS. It's also helpful for those of you who don't work in a tertiary care center in the future or even now. When you decide to do the decision to transfer, if I do have a dissection at the bedside, I might just decide to transfer stat instead of having more time in my emerge trying to get a CT. It's also very important for the differential diagnosis. Of course, sometimes you will pick up a massive tamponade, and sometimes, I don't know, it probably happened to you before, but those severe pain radiating to the back can sometimes be biliary colic, and your management will really change drastically. So that's pretty much what I had to say about the evidence. So let's go into the interesting and fun part. So let's talk about the algorithm that I want to show you today. Today, the three things we're going to be looking at is the heart, the aortic arch, and the other arteries, including the abdominal aorta. And we're going to start where the money is most of the time, the heart. When we evaluate the heart, the part of the aorta we'll be looking at is this ascending aorta, and part of the descending aorta. Let's review exactly what we're going to be looking at. Of course, the probe of choice is going to be your phased array probe or your cardiac probe when you're going to evaluate for the heart. And if you had to choose one view and one view only when you want to assess the aorta, I would actually say that it should be your parasternal long axis view, which most of us are actually pretty comfortable doing nowadays. So this is a normal parasternal long axis view where you recognize your left ventricle, your RVOT or RV here that will just make it simple, your aorta or aortic valve and ascending aorta, your left atrium, and your descending aorta. If you want to do an optimized parasternal long view for aortic dissection, here are my short tips. So to get a better view of your ascending aorta, you can change your probe position. So you're going to move your probe one intercostal space higher, so towards the head, one intercostal space up. You want to get closer to your sternum. I often tell you this, we're very often too far away from the sternum. If you get closer to the sternum with your probe, you're going to get a better view of that ascending aorta. The other thing that you can do, you can tilt the probe towards your right shoulder, and that's also going to help get you an optimized view of your aorta on your parasternal long axis view, of course. The other thing is never forget to put enough depth. You really want to make sure that you see your descending aorta. So this is the optimized view for aortic dissection of the parasternal long axis. Excellent. Now that we have this optimized view, what do we look at? We're going to really be looking at the ascending aorta, the pericardium, and the descending aorta. Let's go into detail in each of them. So what are we looking at for the ascending aorta? The first thing is remember the rule of the thirds. So your right ventricle, right there, should always be the same size as your aortic root and should always be the same size as your left aorta. So they should always be about a third of your parasternal long axis view. So this is a normal view respecting the rules of the thirds. This is a normal video, again, respecting the rule of the thirds. This is a very good illustration of a dilation of the ascending aorta. So if you look at the RV looks way smaller, and actually the left atrium looks really, really small compared to this really big, fat ascending aorta. That's a dilated ascending aorta. That's another example of another dilation of the ascending aorta where really the left atrium looks like it's tiny, tiny. And that's because your ascending aorta is really, really big. How do you know it's big? many different ways to calculate, where's to measure from inner edge to outer edge at the sinotubular junction. It also depends on the size of the patient and also on the sex, with male and men being different. It can be very scary when you start reviewing the literature. But I would say my rule is dilation of the ascending aorta is anything that is bigger than 4 centimeters. It should raise a flag in your head. So just remember 4 centimeters. Good. So that was the case we actually had just a second before. So we know that this is big, but how big is this? We're going to freeze the image, take a measure, and it's 5.5 centimeters. So this is really more than 4. This is dilated. This is suspicious. The other thing that we can notice on this image, and I hope you're able to appreciate this, it looks like there's a little flappy thing right at the bottom of my ascending aorta. That is actually a flap. So not only you have the dilation of the ascending aorta, but you can appreciate maybe a flap right there. What else can you be looking at? Okay, you can be looking at aortic regurgitation or aortic insufficiency. So on the same parasternal long view of your optimized aortic ascending aorta, you look at dilation, but you also look at aortic regurgitation. How do you do this? Well, you're going to activate your color Doppler. So that's a little function in your machine. You activate it, and there's going to be a box that's going to appear. That box, you're going to drag below the aortic valve. When your box is below the aortic valve, what you look for is a regurgitating jet. So you're going to be looking for a jet that comes back towards the left ventricle. So the left ventricle being right there. In diastole, so when your aortic valve is closed, there should not be any blood back there in the left ventricle. Your valve should be étanche, like it should be completely closed without anything. But here we can obviously see that there's this tiny little regurgitant jet in the LVs, and that's aortic regurgitation. Sometimes it's actually much less subtle. Here we can see that there's a massive regurgitation in my left ventricle, right below my aortic valve. That's way more concerning. So that's pretty much it. So when you look at the ascending aorta, you want to look at dilation, aortic regurgitation, and the presence of a flap if you're lucky. Let's look at the pericardium. So what are we looking at exactly at the pericardium? So again, remember the normal view of your RV, aorta, left ventricle, left atrium, descending aorta. That's important to see it. And typically when we see a pericardial effusion on the parasternal long axis view, here's a little red star at the bottom of the screen. It's going to be tracking in front of the descending aorta. So very important to get the descending aorta into your view. So that's a normal view. This is a pericardial effusion on a parasternal long axis view when you can appreciate the descending aorta right here at the bottom of the screen. And here you're going to be tracking anterior to the descending aorta, a pretty large effusion. So that is concerning. If you see someone with a history of consistent with a dissection on your medical history, and you see this, it should raise a flag. This should raise actually a bigger flag. So a complex pericardial effusion, this is a clot. So here we have the heart that is completely squished actually from that big pericardial effusion, but it can be very dangerous. Don't call this an epicardial fat pad or just a fat pad of the heart. This is a clot. One of the ways you can differentiate between a pericardial clot and fat pad is a fat pad should always be moving together with the heart in synchrony. This here has a mixed component. There is some black, pitch black, like we would usually see, but there's also clot. And typically it's going to move in this synchrony. Now it's very fast, but it's going to be moving like this, one on top of each other because they're not together like the fat pad. So very important to make that distinction. So here, very concerning, a complex pericardial effusion, but also a complete RV collapse. You know, we were saying how the heart is squished. This is actually your RV that is completely squished by this increased pressure in the pericardium. That's actually a sign of tamponade. So there's sonographic evidence of a tamponade from that complex pericardial effusion. So pericardial, always make sure you assess for the presence of effusion. And if you see a complex one or a clot, be even more suspicious. What about the descending aorta? The descending aorta, well, the only thing you want to be looking at is it dilated, yes or no? So sorry, this is a view that is flipped. So this is more of an emergency convention type of picture where the left ventricle is here, your aortic root is here, right ventricle, and this is your descending aorta. For the descending aorta, really what you want to have is something that is bigger than 3 centimeters, similarly to the abdominal aorta. Here, so we have a 3.88. That is suspicious for something going on, maybe a type B dissection, dilation of the ascending aorta. That's pretty much it for the heart. So we want to be looking at these 3 structures and all these elements. Let's talk about some of the other views. Sometimes you will have some help from your other conventional view. So this is a subxiphoid view, and the video is going to replay, where you see a dilation of the ascending aorta, but you're also lucky enough to see a flap. So sometimes if you know you're not really able to get the nice views with the parasternal long axis, you give it a try with the other views because you might be surprised, such as in this case. Sometimes there's other views that can be helpful. So here's a parasternal short axis view where you can see right behind the descending aorta. So in a very echogenic patient, you'll be lucky enough sometimes to be able to catch this. And if you do see a flap or you see that it's massively dilated again, that could be a clue. The apical 4 view, here we have a good example. That's the same patient as before. Remember that big complex pericardial effusion with a massive clot? Let's say you're not able to get the other views and you see this, your suspicion is very high now. And also the apical 5-chamber view, you know, when you give it a little bit more, you flatten your probe towards that right shoulder, you will be able to appreciate this sometimes, where we see a dilated aortic root, and again, the presence of a flap. So the other views can be useful. I would say that I do not integrate them consistently in my evaluation, but it's something to keep in mind if you're having trouble getting your parasternal long axis view. Okay, the aortic arch. This is exciting because this is something that you might not be using already. How do we assess for the aortic arch? So the aortic arch, you're going to be using the same exact probes. You're going to be using your phase array probe. In here, what we're going to do the suprasternal view. So you ask your patient to lie completely flat on their back, and you're going to ask them to extend their neck. So chin is looking up, and try to deviate the chin to the right, really to give you that space so you can manipulate your probe. You're going to put tons of gel in the sternal notch, and you're going to put your probe marker looking cephalad, so towards the head of the patient, and you're going to slowly rotate towards their left shoulder or clockwise. This is the view that you should be getting. It's not easy in everyone. Okay, I have to say word of caution here, but it is something that if you practice, you will be better at it. So what are we looking at here? We're looking at a suprasternal view that is normal, where we see the ascending aorta, the arch, and the descending aorta with the left-sided vessel, so left common carotid and left subclavian artery. So pretty cool image. This is my suprasternal view. So this is actually done by myself in the Emerge, where you can appreciate maybe a little bit of my ascending aorta, but mostly what you see are my left-sided vessels and my descending aorta. This is a great example where you see a dissection flap. So here, what we're looking at, we don't do any measures, okay, with the suprasternal view. Why? It's because it is difficult to get a perfect view without any oblique cuts. So really what I want you to look at is if the presence of a flap or not. And here we obviously have a flap that looks like it's coming from the ascending aorta, and actually going to maybe one of those vessels, right, going up to the head. So maybe this patient is actually presenting with a stroke. This is another great example of a flap in the ascending aorta by the suprasternal view, where you can see the flap is actually coming in the descending aorta. So it's actually in the arch all the way down the descending aorta. And this is, I'm so proud of this one. So I was a resident at the Vic with Valérie Aumier, and this is a patient that came in altered mental status, intubated, and apparently had some back pain. And we thought it was a AAA initially, but when I looked at that suprasternal view, you can clearly see the presence of a small, tiny flap that's pulsating with the cardiac pulsation and actually going towards, I think, if I'm not mistaken, it was the left carotid. So this patient came in with a stroke from an ascending aortic dissection. So even though the view is not optimal, you can actually appreciate the flap, and the diagnosis is pretty evident starting from here. Very nice. So that was it for the suprasternal view. What about the abdominal aorta and the other arteries? So the abdominal aorta and other arteries, the abdominal aorta, you're really going to do the same exact view like you would do for a AAA. So you're going to be putting your curvilinear probe and just scanning down from the xiphoid all the way down to the iliac arteries. A dissection will look like this. So don't forget that sometimes it can be useful with some of the most conventional view we have. So here's a flap in the abdominal aorta. Always try to confirm it in the longitudinal axis also. It's really going to help you confirm that this is indeed a flap. And here in those videos, you can actually see that you see it very well in a transverse view, but you can also appreciate it on the longitudinal view. It's going to be the exact same principles for the femoral artery, inguinal arteries, carotid arteries. You're going to see a flap in transverse and in longitudinal. So if you have a patient consistent with, I don't know, a limb ischemia or a stroke, give it a try. It's easy done, and that it might be very helpful to help you with the diagnosis. So that's pretty much the approach. Look at the heart, look at the aortic arch with that suprasternal view, and then look at the other abdominal artery, the abdominal aorta or the other arteries, if you feel that there's a suspicion of guiding you towards maybe abdominal pain or an acute ischemic limb. Let's talk about artifact because that's actually very important. Artifact can be difficult to distinguish between a flap, but here are some little tips that might help you make that distinction. So a dissection flap typically is going to have an undulating motion. So it's going to really be undulating. It's going to be concordant with the cardiac pulsation or the heart rate. It's going to be independent from the aortic wall. So it really doesn't look like it's a reverberation artifact. It's completely independent. You're going to see it on more than one view. And honestly, I would say before you call it a flap, make sure you see it on more than one view to really have that perfect confirmation. And typically a flap, it's going to be distinct. It's going to be very easy to see, not very subtle like artifacts are. This is an example. So here we can appreciate an undulating motion, especially on the longitudinal view. You can see that this undulating motion and of a distinct flap that is concordant with a cardiac pulsation. The artifacts will have a motion that is parallel to the adjacent structure. So typical of the reverberation artifact from the aortic wall, they will disappear as soon as you change your proposition or your view. Typically, the artifacts are going to be linear and are going to be poorly defined, not as distinct as the dissection flap. So this is an example of you see an abdominal aorta and you see maybe, is that a flap? I'm not really sure. So change your view. Again, very commonly in the parasternal long axis view, you're going to be looking at it and you're going to say, is this a flap? Could that be a flap? Or is this a flap? These three are poorly defined. It looks like they are very close to the aortic wall. Don't call that a flap. Make sure that you change your view, you try to see something else. And I have, if ever you're interested, I have a very, very good article discussing all the small little artifacts of cardiac transthoracic echo. It's very interesting. So where do you go from there? So now that you know that there's a simple practical algorithm POCUS that you can use to help you guide your patients with suspicion of aortic dissection, what do? Clinical integration. So if you do have a direct signs, well, you see a flap, you're sure it's a flap, you see it on multiple view, you have confirmed that this is an aortic dissection. Start your treatment, get your esmolol, make sure you decrease that blood pressure, that shear stress, call your surgical consultation right away. So depending on where you work, it might be CVT, cardiac surgery, but call them STAT. You have a diagnosis. Plus or minus CT angio or TEE, depending on your patient, depending on your protocol, and depending on your surgeon, whatever they tell you. If you have indirect signs, so you're like, hey, I think my aortic root is dilated. It's like 5 centimeters. I don't think this patient should have a dilated root. There is new regurgitation, or it's not new. You don't know if it's new, but it's pretty big and you're worried about it. You do have a pericardial effusion or a complex one, and you think there might be a flap. Well, you're suspecting it, okay? Get the things going, get the ball rolling, go to your CT angio, ask for transthoracic echo, plus or minus, depending on your level of confidence, start your treatment and get your surgical consultation. It's very important that we accelerate the diagnosis. And if you do find something on your ultrasound that looks suspicious, get your colleague, get your cardiologist, you might be saving the life of your patient by getting your probe out and assessing for those indirect signs. Okay, now I know you guys are all excited and you really want to bring it back to your next shift, and I strongly encourage you to do so. So many small take-home points for that talk. So POCUS for aortic dissection, although there's limited evidence so far, we know that it's actually very useful for the unstable patient and to accelerate the time to diagnosis. And we know that time is life. So get your probes out. I think I was able to present you a simple algorithm that is very easy to integrate into our core POCUS view that we're already doing, with the exception maybe of the suprasternal view. But if you practice it, you'll be good at it, and you might be very surprised on how you can actually detect a flap one day. And I think there's a very exciting future for TEE. Now that we start having it in the emergency department, I suspect that in the future, it might actually be part of our POCUS assessment to be using TEE for dissection in the ED. So I am available if you have any questions at this time. And I hope we do have yes, we do have a bit of time. Yay. So we do have a bit of time. So I'm going to just, I guess I can still share my screen. Let me just try to find it.
Super exciting. So thank you for that. There's first question is coming from the chat. And so is it possible to have a suboptimal view in the parasternal long axis that mimics a widened aortic root? Like, could you, the angulation of your probe, maybe, is that possible?
Sure, I'm sure it is possible. It really depends, but you know, the parasternal long axis view, when we practice together, I always tell you the same thing, right? You really want to make sure that you have your descending aorta in the view, and your screen should be split in two. You should always have a third, and then your left ventricle. And your left ventricle, you shouldn't be seeing your apex. That is the perfect parasternal long axis view. If you don't have this, it is very tough to interpret. I cannot tell you if your LV is dilated, if I'm not able really to assess if you're not foreshortened or something. So yes, suboptimal views, they are difficult to interpret, and perhaps you should not be interpreting them unless you have, I don't know, the presence of a massive effusion. That, no matter what your view is, you will probably see. But yes, you have to be very careful if you have a suboptimal view.
Great. Any other questions for Laurie?
If not,
actually, I do have a question. Laurie, is I'm at the Jewish general room. Is the coffee machine you're doing?
No, in your.
Somebody brought a coffee machine, so I'll have to thank that person and find that person.
And no, so ask everyone.
I only brought the decoration.
We're all very thankful for it. Thank you. Yeah, no, it's so
well deserved. Just one thing, if ever I looked at everything and it seems that the algorithm I presented today it's never been presented at any conference, published or anything. I want to do something with this, but I'm not sure where to start. I think it would be good to do a project, but it's going to be difficult to recruit. No matter what, if ever someone is interested with aortic dissection and POCUS, I want to get this going. I've been presenting this presentation a few times at conferences, and people are very excited, and it looks like it's a new concept. So anyone interested could email me. My email is right there. Yeah, it would be really cool that we get something going at McGill for this. Thank you.
Awesome. I'm sure you'll get takers. Yeah. Yeah. All right. Thank you so much. Okay. So next up we have Fred giving, this is, I believe, Grand Rounds, is it? Or is it Journal Club? Yeah, Grand Rounds. So on sudden cardiac, sudden cardiac death in athletes. So have at it.
Okay. Okay, can anyone see you can all see my slides?
Yeah.
Okay, perfect. All right, so my name is Frederique, I'm PGY2. Today I'm going to present on sudden cardiac death in athletes. So some objective first. So we're going to review the incidence, the risk factors, etiology of sudden death in athletes. We're going to talk about the training-related EKG alterations and review the different causes of sudden death. So for some background info, so sudden death is the leading cause of mortality in young athletes during exercise. Typically, it's the result of an undiagnosed structural or electrical cardiovascular disease. And exercise may trigger an acute cardiovascular event or sudden cardiac arrest in young people with silent hereditary or congenital heart disease. It's an important topic and it's not as uncommon as we think. This is why I chose this subject. Also in the emerge, we often see young people present with syncope or palpitations, and it looks vasovagal or benign. Often it is, it's often benign, but we have to be able to rule out any potential causes of sudden death. And often they present with subtle or obvious abnormalities on EKG. So this is what we're going to talk about. So the reported incidence of SCD in young competitive athletes varies widely. The different studies on the subject have different methods and are from different geographic regions, which may explain the differences in their results. Corrado and al. Prospectively studied a large, well-defined population of non-athletes and athletes in the Veneto region of Italy over 25 years, and they found an incidence of SCD of 1 per 24,000 prior to their implementation of pre-participation evaluation program. And the rate of SCD decreased to 1 per 250,000 after implementation of a cardiovascular screening program that included an EKG. The US military is a well-defined target population that has a mandatory death reporting system and standardized autopsy protocols. Although the military recruits do not necessarily meet the standard definition of competitive athletes, their regular intense training involved in conjunction with a similar median age, so around 19 years old, makes them a good comparator to the athlete population. And over a 10-year period, they found a rate of SCD of 1 per 25,000 in recruits under the age of 35 years old. Arman and al. Performed a comprehensive review of studies that have examined the incidence of SCD in athletes, and the incidence across of SCD across all the 28 studies varied a lot. But the studies with higher methodological quality yielded a higher estimate of incidence, ranging from 1 per 40,000 to 1 per 80,000. Survival rates of SCA in athletes have significantly improved following widespread implementation of AEDs. And the increasing number of athletes surviving ACA may create the misconception of drastically falling rates of SCD. But overall, the incidence of sudden death in young athletes that less than 35 years old is 0.6 to 3.6 per 100,000 athletes per year, and the majority of deaths are due to cardiovascular causes. Most deaths from cardiovascular disease occur during sport. So can, in the chat, or maybe out loud, I don't think I can see the chat, can you please name some risk factors that you know of sudden cardiac death in the young athletes? I can't see the chat, so I think it's gonna have to be
family history of sudden death.
Yeah, good. Okay.
Known channelopathy. Yeah,
that's good. Yeah, good. So I'm gonna name some of mine, some general. Basically, it's more, deaths are more common in males, with reports of male to female gender differences ranging from 5 to 1 to 9 to 1. Meridian and al. Assess characteristics and outcomes of SCA in middle-aged individuals in a large 12-year prospective study in the Northwestern US region, and they reported a significantly higher incidence of SCD in males with a relative risk of almost 19. Also, the incidence of SCD is higher in African-American athletes. NCAA African-American athletes reveal a 3.2 times greater risk of SCD compared with white counterparts. Also, some geographic areas have a lower risk of SCD, perhaps due to just the differences of prevalence of certain inheritable cardiovascular disorders. And age is also a significant risk factor. So, and the etiology of the SCD really varies with age. There was a 5-year prospective study of exercise-related SCD in the French population aged 10 to 70 years old that revealed that 94% of SCD occurred in recreational athletes, and usually in the 5th decade. In athletes over 50 years old, CAD is the cause of exercise-related SCD 80% of the time. In contrast, SCD in younger athletes less than 35 years old is most commonly due to a variety of congenital cardiac abnormalities, but acquired conditions are also implicated. But there is overlap, especially among the 30 to 50 years old athletes. So again, which sports carry the highest risk? Can anyone have like, does anyone know which sport would be at higher risk?
Marathons, like long endurance sport.
Yeah.
Soccer.
Yeah, football.
Yeah. Sorry. So yeah. Basically, sudden death can occur in any sport, but deaths occur most frequently in the most popular dynamic sports with a start-stop nature, notably basketball in North America and soccer in Europe. In the NCAA, basketball is by far the highest risk sport, and other groups at high risk of STD include men's soccer, men's American football. So this chart shows basically what sport have highest static component and dynamic component. I want to emphasize the class 1A because I'm going to talk about it later in my presentation, but this is the class that's at lowest risk of STD. So low static component, low dynamic component, and includes bowling, cricket, curling, golf, riflery, yoga. And some studies evaluated the relative risk of SCA, STD in competitive athletes versus the general non-athletic population, and whether this risk actually justifies a separate, more advanced PPE program for athletes. Corrado and al. Identified a 2.5 times relative risk for STD due to sports activity in athletes, and another study found a relative risk of SCA of 3.6. Physical exertion through athletic participation triggers potentially fatal ventricular arrhythmias in predisposed individuals with quiescent cardiovascular disease. So this data supports a more intensive screening program for the athletic community. So what do you think is the first cause of sudden death in young athletes?
Occam.
Cardiomyopathies?
Yeah, so yes, exactly. So primary ventricular tachyarrhythmias are the predominant mechanisms of sudden cardiac death, except in Marfan Syndrome, where death is often from aortic rupture or dissection. Cardiomyopathies are the most common cause of STD in young athletes, with hypertrophic cardiomyopathy being the most common cause in USA, and arrhythmogenic cardiomyopathy is the commonest cause in Italy. This difference is likely explained by genetics. Okay, so next, training-related EKG alterations. So regular exercise is associated with enlarged cardiac chambers and increased vagal tone that manifests as specific electrical manifestation on EKG, and it can be normal in athletes. So basically what is considered normal variants include isolated QRS voltage criteria for RVH, LVH, sinus bradycardia, sinus arrhythmia, first degree AV block, incomplete right bundle branch block, early repolarization, ST segment elevation, ST segment elevation followed by T-wave inversion in V1 to V4 in African American athletes, T-wave inversion in V1 to V3 in athletes less than 16 years old, and Mobitz type 1 Benquebec second degree AV block. Isolated increases in QRS amplitude are common in trained athletes, but QRS voltage criteria for LVH with any non-voltage criteria for pathologic LVH, like a strained pattern of repolarization, so ST segment depression, T-wave inversion, or pathologic Q waves are abnormal and they require further evaluation. The borderline findings that are listed there, probably in isolation, they don't present any pathologies in athletes, but the presence of 2 or more borderline findings may warrant additional investigations until further data becomes available. Okay. A common pattern of early repolarization seen in athletes of African Caribbean descent is anterior T-wave inversion in V1 to V4, preceded by G-point elevation and convex ST segment elevation. The T-waves in disease may be asymmetrical or biphasic, and they're not associated with any cardiac pathology. They do not require any evaluation if the patient does not have any symptoms or no family history of cardiac disease. The T-wave pattern resolves rapidly, so within 6 weeks of cessation of training, and follow-up of those athletes over 5 years has not resulted in any fatalities, but it should not be confused with the downsloping ST segment elevation in V1 to V3 found in Brugada-like EKG patterns, which is abnormal. British and French studies suggest that 23% of male athletes of African Caribbean descent exhibit T-wave inversion. It's often deep, often affects the inferior and lateral leads, which is a pattern that is very common to HCM. They also have a greater magnitude of LVH compared with Caucasian athletes participating in similar sports. and they're more prone to exercise-related STD from HCM, according to studies in the USA. HCM has been identified in athletes with contiguous T-wave inversion in the inferior and lateral leads. So T-wave inversion in leads V1 to V4 is a normal variant if the athlete has no symptoms and no family history. But in contrast, investigation is recommended if they have T-wave inversion in contiguous inferior and or lateral leads. So in this image, what you see basically in panel 1 to 4, the T-wave inversion is only in V1 to V3. So this is normal, versus panel 5 has T-wave inversion also in the lateral leads, which is abnormal and would require more investigation to rule out HCM. T-wave inversion in V1 to V3 in athletes less than 16 years old represents the juvenile T-wave pattern. But this pattern is rare in white athletes over the age of 16 and warrants more evaluation, especially to rule out ARVC. Okay, so now we're going to talk about the causes of sudden death. So we're going to start with structural. Can anyone tell me like what they think the diagnosis here is, or what they think is abnormal on this EKG?
Maybe how come?
Yeah. So you see they have high voltage criteria, and also you can see they have narrow Q waves in 1 AVL, V5, and V6. So first we're going to talk about the cardiomyopathy. So hypertrophic cardiomyopathy, it's a primary myocardial disorder caused by mutations within genes encoding proteins, autosomal dominant, characterized by LVH in the absence of a cardiac or systemic cause, and characterized by myocardial disarray on histology. Approximately 25% of affected patients have dynamic LV outflow obstruction due to the systolic anterior motion of the mitral valve leaflet against the hypertrophied interventricular septum. And this creates a subvalvular stenosis. So 25% of patients have it at rest, but during exercise, almost 70% will have this feature. And this is also why, because it's a subvalvular stenosis, this is also why the systolic murmur of HCM increases with maneuvers that decrease venous return, like Valsalva, or moving from squatting to standing, compared to the murmur of aortic stenosis. The prevalence of HCM in the general population is 0.2%. In athletes, it's less, probably because if they have moderate or severe disease, they're not able to increase their stroke volume for prolonged periods, and probably will prevent most people from competing at an elite level. Patients may experience angina dyspnea that is disproportional to the amount of exercise, palpitations, exertional dizziness, and syncope. HCM has a high morphologic heterogeneity, and many affected patients can actually compete at a national level without having any symptoms if they have a mild disease. In those athletes, that's where sudden death is commonly the first presentation. And deaths occur more commonly in male athletes in start-stop sports like football or basketball. And people who are able to do prolonged intensive exercise usually have a structurally mild disease. So they have a mild hypertrophy of 15 to 16 millimeters, or they have the apical variant of the disease. They have a larger cavity size compared with sedentary patients, and they have normal indices of diastolic function and no LV outflow obstruction at risk. The diagnosis is made with TTE or cardiac MRI, but more than 90% have an abnormal 12-lead EKG at rest. So unexplained LVH with a wall thickness equal or more than 13 in females or 15 in males is diagnostic. EKG, so they have LVH with left axis deviation, ST segment depression in leads 1 and AVL, and deep T-wave inversions in lead 1, AVL, V5, and V6. T-wave inversion in the inferolateral or lateral leads is associated with quiescent cardiomyopathy. And this pattern of T-wave inversion with ST depression is common to HCM, but rare in athletes. And these are the most sensitive markers of HCM during screening of athletes. So once a diagnosis is established, the risk of fatal arrhythmias during normal life activity can be predicted through a risk stratification process. And these are the markers of high risk for sudden death. The European and US guidelines recommend that all athletes with HCM should cease competitive sports except for those classified as low intensity, so class 1A. Athletes with HCM protected with an ICD are not necessarily safe to resume competitive sport because exercise-induced shifts in metabolic and electrolyte state can alter the efficacy of the shock. And exercise recommendations are based on the underlying disease process, irrespective of ICD implantation, and an ICD should not be implanted only to allow an athlete to resume competitive sport. So how to differentiate athletes' heart versus HCM? So we know that regular participation in sports is associated with a modest increase in ventricular wall thickness and cavity size, as well as enhanced diastolic filling. This is a reversible physiological cardiac remodeling that enables increased LV filling and stroke volume, even when they have a rapid heart rate to sustain an increase in cardiac output. A small proportion of athletes, especially with endurance sport, have an LV wall thickness of 13 to 15 millimeters, but the majority of people with HCM have a mean wall thickness of 18 to 20 millimeters, but around 8% have a mild hypertrophy only. So a male athlete with a wall thickness of 13 to 15 millimeters kind of falls into a gray zone and should be evaluated for HCM with TTE. Also, physiological LVH is more homogeneous and it's associated with enlarged chamber size and normal indices of diastolic function, versus people with HCM have bizarre patterns of LVH, they have small chamber size and impaired diastolic function. Also, 95% of athletes with HCM have markedly abnormal EKG pattern, and the presence of family history, sudden cardiac death, or low peak oxygen consumption are also things that favor HCM. Idiopathic left ventricular hypertrophy, briefly, so definition is increased LV mass of greater than 500 milligrams in the absence of myocyte disorder, which is the histological hallmark of HCM. Most deaths from idiopathic LVH are described in African Afro-Caribbean athletes. It's unclear if this is actually a variant of HCM or whether it's a genetic mutation that results in an exaggerated hypertrophic response that is different from HCM. Arrhythmogenic cardiomyopathy, the commonest cause of SCD in young athletes in Italy. It's a familial disorder, autosomal dominant, and mainly caused by mutation in genes encoding several cardiac proteins. Histologically, it's characterized by basically progressive death of myocardial cell, and that is then replaced with fibrofatty tissue. Originally it was called arrhythmogenic right ventricular cardiomyopathy, but it's actually a misnomer because it was predominantly thought to affect only the RV, but autopsy series have showed that over 70% also have an LV involvement, and LV involvement is also possible in isolation, and it invariably coexists with RV involvement in advanced cases. Usually the condition manifests with arrhythmias of right ventricular origin and morphological changes affecting the RV, and most deaths in athletes occur during sport, especially soccer, and predominantly affect males. So under conditions of mechanical stress, because they have weakness of cell-cell junction, because they have abnormal proteins, it causes myocyte detachment, which in itself increases the risk of fatal ventricular arrhythmias and sudden death. And then the myocardium is repaired with fibrofatty tissue, which increases again the ventricular arrhythmias and chances of heart failure. Most athletes are asymptomatic, and sudden death is usually the first presentation, but there's a small number of patients that present with palpitation, dizziness, or exertional syncope. There is some evidence that show that intensive ultra endurance exercise may promote changes within the RV that are actually identical to the classic description of the disease, which indicates that AC might be acquired through intensive exercise. The diagnosis requires a combination of clinical suspicion from personal symptoms and family history or ECG imaging studies. It can be difficult to make the diagnosis, especially in the concealed form of the disease, when the ECG may exhibit only very subtle changes and sometimes the imaging is normal. RV is also amenable to endocardial biopsy, but it's potentially dangerous, and AC affects mostly the thinnest portion of the RV. So the EKG shows T-wave inversion and prolonged QRS duration in the right ventricular lead, so V1 to V3. They also have a delayed terminal S-wave duration in V1 to V3 again, epsilon waves, and they have frequent PVC, so more than 1,000 per 24 hours from right ventricular origin that manifests with the left bundle branch block morphology. So another EKG. Athletes with AC should cease competitive sport, except those classified as 1A. Recent studies showed that endurance exercise accelerates the phenotype and increases the risk of arrhythmias in genotype positive family members with AC, whereas moderate recreational exercise may be safe. So for this reason, genotype positive, phenotype negative individual follow the same recommendations for sports participation as athletes with a proven AC. And athletes at high risk of SCD, even after abstinence from sport, include those with a previous history of cardiac arrest, unheralded syncope, VT with hemodynamic compromise, and progressive deterioration of RV function and left ventricular involvement. And this group should be offered an ICD. Dilated cardiomyopathy, it's a rare cause of SCD in young athletes, probably because most patients have a markedly impaired systolic function and they're not able to compete at an elite level. It's inherited or acquired secondary to infection, inflammation, or toxic substances. A genetic etiology should be considered in young individuals with a family history of dilated cardiomyopathy or sudden death below 40 years of age. Morphologically, it's characterized by LV dilatation and impaired systolic function. And a diagnosis of dilated cardiomyopathy is an indication for abstinence from competitive sports, except those classified as 1A. Disorders of the coronary arteries and aorta. So first, congenital coronary artery anomalies. So they're classified as anomalies of origin, course, destination, and size, or number of vessels. So it's highly variable. Anomalous origination of a coronary artery from the opposite sinus is the subgroup of CAs that has the most potential for sudden death. A right coronary artery from the left coronary sinus is the most common variant, but most deaths are linked with an anomalous left coronary artery origin. The majority of patients are asymptomatic and undiagnosed through life, but there's a minority that present with sudden death as first manifestation. Almost all cases of SCD from CCAA occur in athletes less than 35 years old and are linked with exercise. And SCD has been predominantly attributed to mechanical compression of the anomalous coronary artery during exercise if it takes an interarterial course between the aorta and the pulmonary artery, or if the anomalous artery has an intramural course within the wall of the aorta. So exercise then induces myocardial ischemia, which may trigger electrical instability leading to VF and sudden death. The EKG is usually normal. CT coronary angio or MR angiography are the imaging modalities of choice. And the recommendations for sport eligibility are determined by the patient's anatomy, the symptoms, if they've had an MI or not, and the outcome of non-invasive testing. Usually participation 3 months after surgical correction is permitted in cases without prior MI, LV dysfunction, or VT during maximal exertion. Premature CAD. So 3 to 4% of all STDs in young athletes, more common in Japan, Australia, and the UK. It's a common manifestation of familial hypercholesterolemia, and sudden death is often the first presentation in young athletes. The prodromal symptoms of MI may be absent, but they often have peripheral stigmata of hypercholesterolemia, like xanthelasma, corneal arcus, palmar, and eruptive xanthomata. And their presence should raise the suspicion of the disorder. Marfan Syndrome, it's a collagen disorder caused by mutations in the gene encoding fibrillin, autosomal dominant inheritance, and characterized by skeletal, cardiac, and ocular abnormalities. Basically, they have high heart palate, acnodactyly, hyperlaxity. They're very tall, they have a long arm wingspan and lens dislocation. This is an acronym I found on the internet. I thought it was pretty good if you ever have trouble remembering this stuff. Yeah. Affected patients are excessively tall. They usually excel in basketball and volleyball. They also have cystic medial necrosis of the tunica media and of the aorta, which results in aortic dilatation and rupture or aortic dissection. They also have myxomatous degeneration of the mitral and aortic valves, which may also lead to valvular dysfunction, including aortic regurg. And exercise-related increases in aortic pressure may cause aortic root dilatation, dissection, and rupture, causing instantaneous death during sport. For athletes with Marfan Syndrome, participation in sports where isometric stress is a significant component is prohibited, like powerlifting, wrestling. Valvular heart disease. So first, mitral valve prolapse. It's the commonest congenital valvular disorder that affects 3 to 5% of the general population. Most are asymptomatic, but in rare instances, it can be associated with VT. So autopsy studies showed that there is scarring in the posterior papillary muscle and the infrabasal left ventricular wall, which suggests that the stretching forces from the flail leaflet may be the potential trigger for arrhythmias. An athlete with mitral valve prolapse is at low risk of sudden death unless there's a history of syncope or documented ventricular arrhythmias, family history of premature SCD, chest pain during sport, or associated to moderate or severe MR. Also, the presence of T-wave inversion in the inferior leads, extrasystoles conducting with right bundle branch block morphology, or infrabasal scar on CMR are other risk factors for potential fatal arrhythmias. Aortic stenosis, usually due to congenital bicuspid aortic valve in the young population. It's a rare cause of sudden death in young athletes, but a recognized cause. Bicuspid aortic valve may be associated with an aortopathy, which may result in aneurysm or rupture of the ascending thoracic aorta. And sports eligibility is determined by symptoms, aided by exercise testing and TTE parameters like pressure gradients, LV size, and function. Okay, sudden death due to congenital or genetic abnormalities predisposing to primary electrical disorders of the heart. So up to 40% of athletes who die suddenly have no identifiable cause at postmortem evaluation. So they have an autopsy negative sudden unexplained death, which is referred to as sudden arrhythmic death syndrome. So SAD. So this is basically at least 50% of these deaths are attributable to inherited ion channelopathy, like congenital long QT syndrome, Brugada syndrome, and catecholaminergic polymorphic VT. And fatal tachyarrhythmias due to undiagnosed accessory pathways comprise other potential causes. So congenital long QT syndrome, it's inherited as autosomal dominant or recessive trait. Results in abnormalities in cardiac sodium or potassium ion channels. Basically, abnormal shifts in electrical currents result in membrane instability during cardiac repolarization, which predisposes them to polymorphic VT and VF. 15 loci are identified, but 95% are LQTS 1, 2, or 3. So basically what happens is usually adrenergic surges provoke ventricular arrhythmias, particularly in patients with the LQTS1 genotype. Cold water immersion may also trigger it because of the co-activation between the sympathetic and the parasympathetic systems, and the stimulus may occur at a time when the QT does not match the underlying heart rate, which increases the risk of arrhythmia. So it depends also, the triggers also depend on the mutation they have. So usually LQTS1 will be so during exercise and like swimming and diving into water, it's a like close association. LQTS2 usually, so emotional stress, physical exercise also, but loud noises. So sometimes like just alarms or telephone or something like that. LQTS3 often they die during sleep. And it may present with palpitations, dizziness, unheralded syncope secondary to polymorphic VT. And it may also be associated with brief myoclonic movements, which can result in a wrong diagnosis of epilepsy. The EKG, so to have a diagnosis, you need a QTc of more than 440 milliseconds in males and 460 in females. They often have also bizarre flat or peak T-wave morphology alternating T-wave polarity, so T-wave alternance like we see here on the EKG, or prominent U waves. Exercise testing is recommended in all patients with suspected long QT syndrome and often exhibits paradoxical prolongation of the QT interval during the recovery phase in LQTS1 and occasionally LQTS2. Special consideration should be given to athletes in swimming events, especially because of the close association between sudden death and LQTS1. Patients who wish to continue intense exercise should receive recommendations, so avoid hypothermia, fever, QT prolonging drugs, importance of hydration and electrolyte replenishment, and have an emergency plan with an AED. Referral for ICD and restriction to class 1A sports for those who remain symptomatic despite beta blocker therapy, who survive cardiac arrest or demonstrate VT or VF. The US consensus states that asymptomatic may return to competitive sport after 3 months of compliant beta blocker therapy. WPW, it's an accessory conduction pathway between the atria and the ventricles with a predilection to reentrant supraventricular tachyarrhythmias, which may degenerate to VF. The EKG shows a delta wave and a short PR interval. Other findings that suggest WPW include a large Q wave in lead 3, no Q wave in V6, and ST depression in V2, V3, and lead 1 and AVL. Patients with symptoms or AFib are at high risk of SCD and should be investigated with EPS. And the risk of SCD is determined by the refractoriness of the accessory pathway and the induction of AFib. And those athletes deemed high risk should be offered catheter ablation. Radiofrequency ablation is the definitive treatment for patients with high-risk pathways who wish to continue to participate in competitive sport. And usually return to sport after successful ablation is possible after 1 to 3 months. Brugada syndrome, it's an inherited ion channelopathy, autosomal dominant with variable penetrance. So they have a mixed phenotypic expression of the disease. It's a mutation in cardiac sodium channel genes. The prevalence is 1 in 1,000 in Asia and 1 in 100,000 in Europe. They have a propensity to sudden death due to polymorphic tachycardia and or VF. The EKG shows an incomplete right bundle branch block with a high takeoff and cove pattern of downsloping ST segments elevation in several leads, but are most marked in leads V1 to V3. They may present with unheralded syncope or sudden cardiac death, and most deaths occur at slow heart rate, so typically during sleep. Theoretically, the condition should not preclude high intensity sport, but chronic exercise promotes increased vagal tone and subsequent resting bradycardia. Plus, prolonged endurance exercise is associated with a high core temperature of more than 40 degrees, which is a recognized trigger in Brugada syndrome. Asymptomatic athletes with Brugada syndrome should be subjected to exercise testing to exhaustion, and those who do not have any symptoms, ventricular arrhythmias, or ST elevations between 1 and 4 minutes into recovery should not be restricted from competitive sport. And the recommendations are the same for those who are genotype positive but phenotype negative. And ICD is the only treatment to prevent SCD and is reserved for survivors of aborted SCD and those with sustained ventricular arrhythmias or unheralded syncope. So catecholaminergic polymorphic VT, it's an adrenergically mediated polymorphic VT due to, again, mutations within genes encoding proteins. Different triggers, so intensive physical exercise and emotional stress, particularly in child and adolescent athletes. Stress-induced syncope is a clinically recognized manifestation, and the baseline EKG is typically normal. Exercise stress testing may demonstrate multifocal PVCs, which in the context of unheralded syncope should raise clinical suspicion of the condition in patients with a structurally normal heart. VT with a beat-to-beat 180 degrees alternating QRS, so bidirectional VT, is highly characteristic of CPVT, but this is a rare manifestation. So prevention of SCDs is, oh no, it's not, okay. So therapy with beta blocker and or flecainide and avoidance of moderate to high intensity exercise, and individuals with ongoing VT or syncope despite pharmacological therapy and lifestyle modification should be offered in ICD. All right, so last part, sudden death due to acquired cardiac abnormalities. So first, myocarditis, usually due to a viral illness, including COVID, accounts for 3 to 13% of all SCDs in athletes. It's characterized by basically inflammation and subsequent focal necrosis of the myocardium that is thought to be the substrate for malignant ventricular tachyarrhythmias causing sudden death. The arrhythmias may be present during the acute and the chronic phases because of so for the acute is the acute inflammation, but they also have post-inflammatory myocardial fibrosis, which can also cause arrhythmias. And in the acute phase, ventricular arrhythmias vary from isolated ventricular ectopic beats to complex tachycardias that can lead to sudden death. Most patients experience cortisol symptoms and a mild febrile illness. However, sudden death is in a relatively asymptomatic is a common presentation. Overt cardiac symptoms are quite rare and include chest pain, dyspnea, and palpitations. EKG shows usually non-specific ST and T wave abnormalities, but it may also be normal. And echo may also be normal in mild cases. A raised troponin is useful in confirming the diagnosis in an athlete with a febrile illness with chest pain and non-specific EKG abnormalities. Non-invasive cardiac MRI is useful in making the diagnosis and monitoring disease progression. The extent of inflammation can be identified with late gadolinium enhancement and can help predict subsequent risk of sudden death. And athletes with acute myocarditis should be temporarily restricted from physical exercise until they have complete recovery. However, VT may also occur, as I said, in the chronic phase of the disease in the context of post-inflammatory myocardial scar. So athletes with myocarditis should be assessed no earlier than 6 months after initial presentation with an echo, CMR, 24-hour monitor, and exercise test. Both US and European experts allow athletes to resume competitive sports when their LV function has returned to baseline, their throat inflammation and heart failure have normalized, and there are no clinically relevant arrhythmias on Holter. Commotio cordis, it means disturbance of the heart in Latin. Basically, it's sudden death from VF, resulting from a blunt trauma to the chest wall. The incidence is higher in children and adolescents because they have a relatively thin and compliant chest wall. It often results from an innocent appearing chest wall blow, usually in sports with small dense projectiles like baseball, field hockey, lacrosse, ice hockey, karate, judo. So basically, usually they collapse from sudden cardiac arrest due to VF, and usually it's instantaneous. What happens is, so they have the chest wall blow during a vulnerable period, like a vulnerable window just before the peak of the T wave, which is a time that vulnerable to VF. Then they have a rapid rise in LV pressure, which is thought to activate ion channels that result in premature ventricular depolarizations that then trigger VF. Autopsy findings typically show normal cardiac anatomy with no evidence of injury, and survival after commotio cordis is approximately 15% and is only possible with rapid defibrillation. Well, some take-home points. So exercise may trigger an acute cardiovascular event or SCA in young athletes with silent congenital heart disease. HCM, #1 cause of SCD in USA, arrhythmogenic cardiomyopathy, #1 cause in Italy. So the presence of exertional chest pain, dyspnea that is disproportionate to the exercise performed, palpitations, dizziness, or syncope during exercise warrant evaluation. Often they are asymptomatic, but many conditions have specific EKG abnormalities, and it's important to be able to recognize them. And the #1 factor affecting survival is defibrillation. So thank you to Valérie Aumier, who helped me with my presentation, and to Céline Altuntero, a librarian at McGill University, who helped me with my research. Thank you.
Wow, very comprehensive. Great job. Questions?
Just a little something. Frederique was excellent, super good. Just something that to remember when we talk about the the prolonged QT in athlete. There is just like in the congenital, there is like the most common is the Romanov-Ward syndrome, something you just have to remember. And the other one, also associated with deafness, is the Lange-Nielsen syndrome. So when you see someone and you ask them about like sudden death in their family, ask them if they're deaf, if there's a cousin who's deaf, because that would run in the family as well. But otherwise, I have to say that that was an excellent talk, Frederique. Very good.
Thank you.
Yeah, very comprehensive. Awesome job. Thank you. All right. So moving on, we have Justin with cat topic.
Hey everybody, welcome to my cat presentation. I have one disclosure. I have birds chirping in the background, so you're going to hear them. I have no way to block them out. It's their peak playtime right now.
So we're not hallucinating then? No hallucinations.
Not hallucinating. They're real birds,
okay.
And they
Solid.
might, fly in front of the screen. So let me see.
Good stuff.
Can you see? Can you see my presentation?
Yes.
Okay, it's taking up the full screen.
It is.
All right. So welcome for those who I haven't worked with before. I'm one of the +1s in the R3 program, and we're going to be talking about POCUS and ocular emergencies. So without further ado, let's just review the anatomy of an eyeball. We have the front of the eye and the back of the eye. In the front, we have the anterior chamber, with all of these intricate structures like the lens and the iris and the aqueous body, many of which we can see with our naked eye or with a slit lamp. So in the back of the eye, we have the posterior chamber, where we have this big, dense gel-like substance called the vitreous body. Vitreous actually means glass-like. And then you have this precious retina that lines the back of the eye. So my presentation is really talking about the back of the eye and the role of POCUS for that. If you were to look through the pupil in perfect fundoscopy, this is what you're going to see. To the medial aspect, you'll see the optic disc and optic cup with blood vessels coming out of it. This is where the optic nerve is going to the back of the brain. And then to the lateral side, you see this darker area where you see the macula and the fovea. Now, no one has ever had a fundoscopy examination like this in the emergency room, because it's basically like looking through it's like looking for a tool in your garage with a flashlight, like a little flashlight. So on the right, you see a normal POCUS of an eye. So in the anterior chamber, you see the eyelid, the anterior chamber, the lens, and then this big hypoechoic vitreous body with the retina in the back. So a more accurate question for my cat topic is, what is the utility of point of care ultrasound for evaluating posterior chamber pathology of the eye in emergency department patients? And in particular, the thing that we really care about here is retinal detachment, because that is the emergent diagnosis that if we get them to ophthalmology soon enough, we could potentially save a patient's vision. So that's my primary interest in this topic. If we're doing this in a more explicit PICO format, the patient population that I'm addressing is emergency room patients that we would see coming in with ocular complaints that's concerning for retinal detachment or other posterior chamber emergencies. The investigation, this is a diagnostic question, is ocular point of care ultrasound performed in the emerge by emerge physicians. The comparison is that of an ophthalmologist's final diagnosis, assuming that they have fancy tools that we don't have, and we're basically using their final diagnosis as the gold standard by which we compare. And the outcome is the accuracy of POCUS for identifying these posterior chamber emergencies in terms of specificity, sensitivity, and whatnot, so that we can use that information to help guide what we do in the emergency room, change our practice. So an outline of how I want to, there's the birds. I'm going to start with a quick review of an approach to acute vision loss, and then quickly review the pathophysiology of retinal detachment and its friends, vitreous detachment and vitreous hemorrhage. And then we'll go into the evidence, focusing on this first paper that was only published a couple of years ago by it's a typo, Laham et al. Because I think it sort of shows you how studies like this how most of the other studies are performed in a pretty similar way, but this is the probably the biggest one and the most compelling study that we have to date. And I'll do a quick review over some of the other studies that do POCUS in the ED. And we also have a systematic review and meta-analysis to kind of bring it all together. And then that leads into some discussion and questions. If there is a little bit of time left over before the break, I also have a 4-minute video from MRAP that shows you how to do Ocular Pocus as a review. If we get to that, if not, then I'll just put the link in the chat. So here's my approach to acute vision loss. Some things that are important to ask on history would be monocular versus binocular. If you have a binocular vision problem, okay, so this is actually a typo here. Binocular is more likely to be something intracranial, whereas monocular is more likely to be something ocular. And then we're going to ask the usual things like onset of duration, associated symptoms like headache, was there a history of trauma, flashes and floaters, and visual field loss. On exam, certainly we're going to be doing visual acuity. We're going to be looking at the eye, including a slit lamp exam. A neuro exam is important, including cranial nerves, visual fields, extraocular movements. We'll do our best fundoscopy in an ideal world. We know it's hard to do in the emergency room with an undilated exam, but we do it. And tonometry if you're worried about certain things like glaucoma, but probably not for all cases. In terms of acute vision loss, it can be divided into painless and painful. Painless, we're going to be talking about retinal detachment here, as well as posterior vitreous detachment and vitreous hemorrhage. The other kind of class is a bit less common to have a retinal, central retinal artery occlusion or central retinal vein occlusion. And then other stroke symptoms from the brain itself. These first, like the CRAO is basically a mini stroke of the eye, whereas other stroke symptoms that affect the occipital lobe, for example, can cause vision changes as well. Painful vision loss, we're dealing more with acute glaucoma. Optic neuritis is usually painful, but not always painful. And giant cell arteritis is one that we never want to miss. There are some other kinds of causes for flashes and floaters like migraine headache, head trauma with concussions. You can see stars and floaters. Other causes like wet age-related macular degeneration, and conversion syndrome obviously is not a diagnosis that is for us to make, but just keep in mind that there are other reasons that people complain of these ocular symptoms. So in the top left corner, upper left corner, we see a vitreous detachment. So this, as you get older, this vitreous body tends to shrink and harden, but it also it liquefies, and there will be certain pockets of liquid within this vitreous. And as it's shrinking, it'll tug onto the retina and stimulate it, which our brain perceives as flashes. So patients will have flashes in the extreme periphery of their vision. And then if it succeeds in detaching completely, you will see a dramatic increase in the floaters, which are abnormalities within the vitreous that are casting a shadow on the retina. And on the right here, you have a retinal detachment. And what actually usually happens with the non-traumatic retinal detachments is that you have the vitreous will kind of tear a little hole in the retina. Then you have fluid that's able to go into that subretinal space, and it causes that little flap to come out and get worse and worse. So that's actually kind of what's happening with a retinal detachment. Some features, the average age of onset is 55, so it does increase as you get older, but it's not necessarily a disease of the elderly. Risk factors include myopia, especially severe myopia. You can see this as early as the 20s, 30s, and recent cataract surgery is a big one as well. It's commonly, but not always, preceded by a posterior vitreous detachment. So the classic story is that you have some sudden onset of flashes or floaters, or, floaters are kind of common. Like I see some floaters right now if I look at a kind of like a homogeneous wall. But if you see an abrupt increase in the amount of floaters, that's concerning for a posterior vitreous detachment. And then as the retina is detaching, you'll see a dark veil or curtain classically that comes down in one of your fields of vision that can cause peripheral and or central visual acuity loss. And it's important to differentiate, maybe not so much for us, but for the ophthalmologist, a macula on versus macula off. That is, Is the retina, is the macula preserved, and you can tack down this retina in time to save that person's vision, versus if it's the macula off, the ophthalmologists are not, they don't see these patients as urgently because likely that vision is already gone. This is a picture I got from athomewithaShley.com about how to fix wallpaper bubbles, because I think it's kind of a nice image of what happens with the retinal detachment. You have this like bleb underneath the retina, and it's kind of hard to take these things out. So maybe if we have time, I can also show you how to take out wallpaper bubbles. This is bold text from Tintinelli, just to kind of emphasize the limitations of POCUS here. Diagnosing a retinal detachment or a tear or a vitreous detachment requires a dilated, indirect ophthalmoscopic evaluation by an ophthalmologist within 24 hours. So just to emphasize that this does not replace the definitive diagnosis and evaluation by an ophthalmologist. In terms of ocular pocus, a little background. Some of this comes from a narrative review that was published in 2015. It's been used since the 1970s, the current technique since about 1987. We're going to be talking about its role in non-traumatic retinal detachment. It also has a role in eye trauma, such as foreign body, hemorrhages, and globe rupture. But again, we shouldn't be, we should be very cautious about putting an ultrasound on an eye that we're suspecting globe rupture. It's also being described to evaluate intraocular pressure, as well as there's some emerging evidence for its role in CRAO, which I don't really get into here, but it's something to keep in mind for the future. So as you see in traumatic, we're not going to be talking about these things, but ocular pocus has a role there. We can see little schematics here that I'll circle back to later about retinal detachment, vitreous detachment, posterior vitreous detachment. And then for intracranial pressure, you see the increased nerve sheath of the optic nerve. This is kind of what it looks like. We have a bunch of goop on someone's eyeball, and we're using our high frequency linear probe, and we're doing a sagittal and a transverse view of the eye. This patient has a tegaderm over the eye to protect the goop from getting in the eye, and you can see the patient looks much happier. And this is something that we can consider for the comfort of our patients. Okay, let's get into the evidence. I'm mindful of the time. Hopefully we have time for some questions after. I'm going to be focusing on this study by Laham et al., published in 2019 in JAMA. This is a large-scale multi-center study that determines that's objective is to determine the utility of POCUS for specifically retinal detachment, vitreous hemorrhage, and vitreous detachment, emphasizing that we're mostly concerned with identifying early retinal detachments so we can do something about them. So this is a multi-center, prospective, as opposed to retrospective, observational diagnostic study, as opposed to experimental study, or as opposed to a therapeutic study. Convenient sampling of patients over the span of just over 2 years. We're presenting with symptoms for which one of these diagnoses was suspected, and symptoms included blurry vision, flashes or floaters, vision loss, and then all of these patients underwent emergent ophthalmology consultation so that they could reference the POCUS results against their diagnosis. So there's 4 sites, 2 academic sites. All of these are in California. The 2 academic sites, UC Irvine and USC, UCLA, and Loma Linda. All of these sites had emergency medicine and ophthalmology residencies, as well as EM ultrasound fellowships. There were 75 different practitioners that evaluated the patients, a mix between attendings, residents, and supervised physician assistants. And they had variable POCUS experience. And before enrollment in the study, all the practitioners had basically an hour-long session, 30-minute lecture, followed by a 20-minute hands-on scanning of healthy volunteer models. So any patient presenting to the ED with ocular symptoms was eligible for the study. So basically what it looked like is you have undergraduate research assistants hanging out in the emergency rooms between 8 a.m. and midnight, so they weren't there overnight. And they would scan the charts for things that might fit the study. they would ask the attending or whoever the practitioner was, does this patient have a concern for, RD, VH, or VD? And if the staff said yes, then they would independently approach that patient and enroll them in the study, for which there was verbal consent and written consent. And then obviously the practitioner would have to do the ultrasound. They excluded patients under the age of 18 if they didn't speak English or Spanish, if they declined enrollment, I think obviously. Importantly, they didn't include ocular trauma or suspicion of globe rupture for obvious reasons. So in terms of the protocol, the first step was POCUS performed by the treating practitioner. They used one of these 2 ultrasound machines with a linear high frequency probe with a dedicated ophthalmology setting. Patient could have been upright or supine. They had both sagittal and transverse views, and they had both static and kinetic exams. So static as in patient holds their eye still and you are fanning the ultrasound probe through the eye, versus kinetic, the probe stays still and the patient is asked to move their eye. Then the patients all had ophthalmology consultation, and they were blinded to the results obtained by the POCUS in the ED. So here's some images of what these things look like. On the left is the retinal detachment. Importantly, it's tethered at one spot at the back of the eye at the optic disc, and you see this flap of retina within the posterior chamber. The second one is a vitreous detachment. It's a little more difficult to kind of differentiate that from a vitreous hemorrhage, I think, but you can get a sense of the difference here. And if we have time for that video at the end, I think it'll be even more clear. Here are some schematics of a retinal detachment as it's tethered to that, the optic nerve. A vitreous detachment is not tethered and has this kind of hyperechoic at the back of the eye, and then there's a vitreous hemorrhage. In terms of how they actually did the study, statistical analysis, they collected the data via portable devices, and then they transferred it to an Excel spreadsheet. The primary endpoint was the diagnostic accuracy of POCUS for evaluating the diagnoses. And then they calculated the sensitivity, the specificity, positive and negative predictive value, and accuracy compared to the ophthalmologist's final diagnosis. They ended up with 225 patients. They had estimated a 15% incidence of these diagnoses, which is a pretty rough number just based off previous results. And they estimated at least 80% sensitivity based off prior data. So they calculated a sample size of 225. So of 252 patients they approached, 13 declined enrollment. And of those that were enrolled, some had incomplete data, didn't get ophthalmology consultation, or they withdrew. So of the 225 patients included, I think the bottom is a little bit confusing because that's actually the numbers of final diagnosis by ophthalmology. So 47 of the 225 ended up having a retinal detachment as per ophthalmology. 54 ended up having vitreous hemorrhage. 34 had vitreous detachment, and 90 had none of the above. Chirp, chirp. So of the 225 patients, 60% were male, 40% were female. The mean age was 51, and there was a wide range from 18 to 91. You see that really the vast majority of the patients came from one site, UC Irvine. 34 came from an UCLA County Hospital and a UCS Medical Center. 34 came from this other site, 14 from the UCLA Olive View, and only 4 came from Loma Linda. So take the multi-center with a grain of salt. There were 75 unique practitioners, of which 20 were attending physicians, 8 were fourth-year residents, 17 were third-year residents, 11 were second-year residents, 14 were first-year residents, and 5 were physician assistants. The average enrolled patient per practitioner was 3.6, and there was a range from 1 to 8. So obviously you needed to do at least 1 scan to be one of the 75 practitioners. But they did put a limit of the amount, because in some of the other studies you have, 1 or 2 of the practitioners who did way more scans than some of the other residents, for instance. So you can only do a maximum of 8 scans. So just to review, the ophthalmologist final diagnosis, 47 had retinal detachment, 54 had vitreous hemorrhage, 34 had vitreous detachment. And the prevalence of disease overall was 36%. So if you do the math, at least some of the patients had more than one diagnosis. So the results for retinal detachment, 47 had retinal detachment, and POCUS correctly identified 46 of these 47 cases. That gives a sensitivity of 96%, 96.9%, and those are the confidence intervals within 95%. Of the 176 that were determined to be negative for retinal detachment, POCUS accurately ruled out 156 of them for a specificity of 88.1%. Coming along to vitreous hemorrhage, 54 had vitreous hemorrhage by ophthalmology. POCUS correctly identified 46 of the 54, which gives a sensitivity of 81.9%. And of the 176 that were negative for this, the specificity was 82.3%. So for vitreous hemorrhage, a little bit less sensitive and specific, but still above 80%. And I'm going a little bit fast because I'm mindful of time. So vitreous detachment, on the other hand, there was 34 that were identified by ophthalmology. 19 of the 34 were picked up with POCUS, so that gives a sensitivity of only 42.5%. On the other hand, it was accurately ruled out most of the cases that were determined to be negative by ophthalmology, so it was specific at 96%. Here's just another way of putting together this data that I won't get into now, but sensitivity, specificity can translate into a positive and negative predictive values, as well as the accuracy. Just to review where these numbers come from that I think we all know. And so in conclusion, they said that, POCUS can be used to quickly identify these diagnoses and to confer some additional information with the numbers that we've seen. Some of the limitations, it's not clear how this will translate into other settings. The sites involved were all had ophthalmology on hand. They all had residency programs with staff that were trained in a certain way, and this was all kind of in one geographic area. The amount of training required to be proficient in ocular POCUS wasn't addressed, so whether that hour training session was enough to be considered proficient is not clear. The patients were also only enrolled for a certain amount of time, so it's, what is coming in between midnight and 8 a.m. Could affect results. They also don't distinguish MAC on versus MAC off detachments or retinal tears. And the practitioners were not masked to the patient's history or physical exam, obviously. So I already have a suspicion of what I'm looking for when I'm doing the POCUS, how worried I am for retinal detachment, for example, and how does that influence what I find on POCUS. A quick review of some of the other studies. There's this one here preceded the study that we're talking about by 8 years by China Renal. Basically, it does a very similar kind of study protocol. It's prospective observational study that was at one single center. They had POCUSs obtained for 101 patients over 1 year with 31 unique practitioners. And then they ended up with 90 patients that were included in the study. And as you can see, they have pretty similar results overall. So if the sensitivity for POCUS for retinal detachment, they're only focusing on retinal detachment, was 97%, and specificity was 92%. Another study by Useni et al. Around the same time obtained 48 patients by 15 unique practitioners. And you can see that, you have at least some of the attendings had way more experience with POCUS, but they also have very high sensitivity and specificity for both cases. Another study here by Kim et al. Has slightly different results. Basically, what they have is they enrolled 126 patients that were eligible participants, and in this case, what they had more essentially they had more false positives and false negative retinal detachments. So in this case, the sensitivity was only 75% for POCUS for detecting retinal detachment, while the specificity remained high at 94%. Here we're all dealing with cohort prospective studies, but fortunately we do have some meta-analysis available to kind of bring it together. This is a meta-analysis and systematic review by Parasternal that was published in 2020. They did a search of over 1,000 unique citations. They reviewed 116 full texts, of which ultimately there was 9 studies included in this meta-analysis, which includes all the studies that I talked about so far. So you list them here. You can see the Kim study, the Laham study that we talked about, the Shiner study. And then you can see all 9 of them at least studied retinal detachment, whereas 5 of them did vitreous hemorrhage, 4 of them did retinal detachment, and they also comment on other things like lens dislocation, foreign bodies that we won't talk about here. The overall sensitivity that they got was 94% sensitive for retinal detachment and specificity of 94% as well, which gives a positive likelihood ratio of 16.6 and a negative likelihood ratio of 0.064. And then you can see the results for vitreous hemorrhage and vitreous detachments were similar to the study by Laham et al., where you have a lower sensitivity for vitreous detachment, but otherwise the sensitivity and specificity is quite high for all 3 diagnoses. This is kind of what they did in, you can kind of have a visual appreciation for the sensitivity and specificity of all these studies. You see the Kim study that only had 75% sensitivity is the one here that looks a bit lower, but otherwise the confidence intervals are relatively wide for most of them. It's smallest in the Laham study because there was the most patients involved. But you can see that most of these studies show a very good sensitivity and specificity for retinal detachment here, and then they do the same thing for all of the other diagnoses. And so the conclusions from this meta-analysis are basically that trained EPs can perform ocular POCUS with enough sensitivity and specificity to rule out retinal detachments for low-risk patients, perhaps, and rule in retinal detachments for high-risk patients. That being said, it's not like we can actually do anything about a retinal detachment. They need to see an ophthalmologist, and more particularly a retinal specialist, in order to possibly save that patient's vision. So, and then limited data suggests that POCUS is moderately accurate for diagnosing vitreous hemorrhage and poorly accurate for diagnosing vitreous detachment. This is just, I won't really get into this, but basically there was another meta-analysis available that showed similar results. This was published in 2015 or so, just to kind of corroborate that. And they found among ED providers that the POCUS was 92% sensitive and 91% specific. They also, comment on one of the limitations being that the utility of POCUS really depends on pretest probability of the disease. So the prevalence in these studies range quite a bit, from anywhere from 7% to 53%, depending on, they broke it into patients in the emergency versus not, and they also broke it into ED providers versus radiologists doing the POCUS, all finding that that POCUS was sensitive and specific over 90% for retinal detachment. Okay, so just to bring it all together, I know I'm running over time. What does this mean for me? This is kind of the summary chart that I made. So if I have a patient who gives a really good story for retinal detachment, that they're at high risk of it, and my POCUS is positive, then it's very likely that this is the real deal. Does it really change what I'm going to do? Maybe not. They're going to need emergency ophthalmology anyways. But with this positive result, perhaps that'll make them get seen faster. If I say ophthalmology, I have this story, I think it's highly, I'm concerned about a retinal detachment and I see one on POCUS, perhaps they're going to see that patient sooner. On the other hand, if you have a high risk story and you don't see something on POCUS, it has some limited utility because they probably still need to see ophthalmology urgently, maybe not as emergently, but it's important to recognize that it's easy to miss a vitreous detachment. So someone comes in with flashes and floaters. Maybe I don't see anything in my POCUS, but in fact, they've just torn a little tiny tear in their retina, and tomorrow they're going to have retinal detachment with a visual field loss and possibly permanent visual loss. So the only way, these patients still need to see ophthalmology so they can have that dilated exam. They'll actually search for little retinal tears and fix them before it becomes a bigger issue. So probably limited utility in that setting. If you have a low risk patient, but the POCUS is positive, this is a bit less common. I guess it would change management because POCUS is specific. You're certainly going to want to have them see ophthalmology emergently. And perhaps the most interesting would be a low risk patient with a negative POCUS, i.e. if they have a more likely reason for their diagnosis, like you're thinking it could be an ocular migraine or a concussion or something, then perhaps that could avoid unnecessary emergent referrals, or at least they could see ophthalmology, sometime this week, for example. So some of the general benefits, just to summarize, this is widely available, it's quick, it's non-invasive. This can help ophthalmology prioritize when they see the patient who needs emergent or emergent versus non-urgent evaluation. And I think in particular, it's interesting for rural and remote settings because we can help determine urgency for transfer to tertiary care. If you're at the Jewish and you have something that is concerning for retinal detachment, it's pretty easy to get them to see ophthalmology within 24 hours, but that's not the case in Iqaluit. So perhaps this can help avoid unnecessary transfers in these patients. Remember that POCUS does not replace the ophthalmologist dilated indirect evaluation. It is provider dependent. It's not clear how much training is required to entail proficiency. There was some of these studies that show that practitioners with more experience had less false negatives and false positives, but that wasn't really addressed here. And then these studies also don't address, length of ED stay or whether costs were saved by reducing need for evaluation or risk of further vision loss. So key points, I know I'm running out of time. POCUS performed by ED physicians is sensitive and specific for retinal detachment. It might be able to help rule in a retinal detachment for a high-risk patient, although they're going to see ophthalmology anyways, and it might help rule out retinal detachment for low-risk patients. It's moderately accurate for diagnosing vitreous hemorrhage, and it's not very sensitive for vitreous detachments. Here's a video that I'll post in the chat. And if you want to know how Ashley got the bubbles out of her wallpaper, she used this wallpaper adhesive. I think she tried with a paper clip, and then she used a little syringe to kind of suck the air out. So I can also put a link to that if you have bubbles in your wallpaper. Thanks, Ashley.
And it's always good to get advice from, in multiple ways in life. So awesome. The summary slide that you had, like with the table, actually did, I think, somewhat answer one of our first questions from the chat. There was a comment as well related to, just it would be interesting if a study existed that would say it's safe to delay ophthalmology referral till the morning, if the ultrasound is negative, which you somewhat chatted about near the end. And I think that would be great if there was more research in that area, such that low risk, negative POCUS, but maybe you're concerned, but maybe ophtho can wait until the AM or something like that. So interesting.
Yeah, I don't know if POCUS can really negate the need for ophthalmology to see the patient, because even when we have patients, I think they're having, flashes from a migraine or something, we're usually not comfortable enough to hang our head on that, unless, the patient's had this before, they've seen ophthalmology, everything was negative, they're having similar symptoms. But nonetheless, I think if it's the difference between, okay, I have a concerning story, I see retinal detachment, I think it's a MAC on, retinal detachment, and you can relay your POCUS results to ophthalmology, they might be able to save that like today. So those hours of difference might make a difference.
Yeah. Awesome. Okay. Well, thank you so much for that. And I think you said you'd post that EMRAP, I think, video in the chat as well. That'd be great.
Yeah, if you have access to MRAP, but it's a good video.
Yeah.
4 minutes.
And thanks for the wallpaper advice as well. So
It was nice.
yeah,
I'm happy
all
she got
right.
the bubbles out.
Okay, all right. So we have a break until 10:20. So so everyone, go do what you got to do, and then we'll be back with Dr. Melanson and CPR ACLS updates. Okay. So welcome back from break. Dr. Melanson is there. I can see his screen share.
Excellent.
Hi there. Okay.
Good.
Yeah, look, the screen looks great. So go ahead when you're ready.
Okay, welcome everybody. So this is called ACLS Update, and it's really just a bunch of topics that have to do with ACLS, primarily from the 2020 and 2021 update guidelines from the American Heart Association and ICOR. It's also partly, I sort of do these lectures about once a year to the critical care fellows and to the internal medicine residents who are on the Code Blue teams. I'm one of the co-chairs of the Code Blue committee at the MUHC. Again, we're going to cover a lot of different topics as we go through. Nothing will be in depth. It'll be fairly, every point will be brief. This type of format usually works better in an interactive format, which is hard with Zoom. So what I would suggest, if you have any particular questions, just put it in the chat, and hopefully one of the chief residents can keep an eye on the chat and interrupt me if some questions come up. I have no problem being interrupted for this talk. It doesn't have to flow smoothly from start to finish. Okay, so with that, welcome everybody, and let's begin. Already a problem. Here we go. Okay, so the first thing I'm going to talk about are the new interim guidelines that came out in October about COVID CPR, or a protected code blue in the face of somebody who's COVID positive or potentially COVID positive. So as you probably know, the MUHC has protected code blue protocols that have been in place since the start of the pandemic. Based on this new guidance that's come out, the Code Blue Committee will be reevaluating our current protocols in January, but at the moment we're not permitted to change them until the provincial body deems that it's okay in Quebec. And I must say, since these have been published, the Omicron situation has come out, and I'm not sure that the fairly rosy picture that the guidelines are painting right now still holds. Anyway, this is a case, we'll start off with a case. This is a case from Sunday night in the emergency department. I was on in the ICU overnight that time. 80-year-old male, minimal comorbidity, very active guy, still has a job, still works, vaccinated ×2, last vaccination 5 months and 29 days ago. And I highlight that because he tried to get the booster twice in the past month, but was refused both times because he hadn't made it up to the 6-month point. And he had an appointment this past Tuesday to go get his vaccination. His business partner tested positive, so he knew he's exposed. He had symptoms for 2 or 3 days. He tested positive the day before. He was unwell at home all day, and then Urgence Santé was called. He was found to have been a PEA arrest when they arrived. They attempted resuscitation for 45 minutes, and then they got ROSC and they transferred him to the emergency department. So the first thing before we go back to the COVID issues, the resuscitation committee of the Department of Emergency Medicine, so McGill-wide, is looking at a few things that we're interested in adopting across the McGill hospitals. One is the concept of the 0-point survey. And there's this paper that was published in the last couple of years by the usual suspects, if you listen to EM Crit, that states it gives you a fairly standardized approach in terms of how to ready yourself, both physically and psychologically, how to ready your team, and how to ready your environment when you're getting this call from, you know, the white phone call from Urgence Santé, say we're bringing in this 80-year-old who's COVID positive, who had a PEA arrest. So I'm not going to go into that in detail right now. Just I would recommend that everybody have a look at this paper, and we're hoping to say more about this in the upcoming year. So this is the interim guidance for CPR with confirmed or highly suspected COVID-19. And what they're saying is that the pandemic has evolved a lot in the last 18 months to 2 years now. We have a much more accurate understanding of transmissibility than we did before. PPE availability is now much more secure. I remember the first couple months, every weekend, there would be some sort of emergency meeting in the hospital with a fear that we weren't going to be able to make it through the weekend with an adequate PPE supply. There's now widespread vaccination of healthcare workers. And what they're saying is obviously some places are going to be much higher risk than others, and you should modify based on your local risk as well, these general guidelines that they're putting forward. So they also make a big point that cardiac arrest survival outcomes in 2020 worsened significantly versus previous years. And they're attributing that to several possible factors. One is COVID-related cardiac arrests are obviously much more severe, and you're much less likely to survive than other causes of cardiac arrest. There is a lot more emphasis on termination or resuscitation guidance. There's a lot of places that had local crisis standards of care where they were not as aggressive or didn't resuscitate for as long. There were a lot of issues with patient hesitancy and delays to care. So coming to the medical system a lot later because of a fear of contracting COVID in the medical system. Overwhelmed EMS services, and then the delay of chest compressions and defibrillation for putting on PPE. And also clearly, anyone who's run a code in full PPE knows that it's a lot more challenging in a lot of ways than without it, particularly in terms of communication between inside and outside the room, and also communication inside the room. And then also the PPE itself becomes increasingly more uncomfortable as the arrest goes on. So that's their points, that there is these worsening survival outcomes, and we have a lot more information now in terms of the risks of to the healthcare worker. So they're making the statement that the risk to the patient by withholding or delaying the response to cardiac arrest is extremely high when compared with a much lower risk that the resuscitation provider will contract COVID-19 and develop serious illness. And the risk is particularly low with vaccinated healthcare workers or unvaccinated healthcare workers wearing PPE for aerosol generating procedures. Okay, good. So they go on to say that, yes, but the data regarding which procedures are aerosol generating or not is still uncertain, and is still an act in evolution. Back at the beginning, we were particularly concerned with the experience from SARS in Toronto. In Toronto at that time, almost 50% of the people who contracted SARS and were hospitalized were healthcare workers. In fact, there's this famous case of the physician who saw one of the original people who came from Hong Kong with SARS, got sick, got admitted to hospital, and then had a prolonged, difficult intubation on the floor with an awake intubation technique that ended up infecting multiple other healthcare workers. So we were really concerned at the beginning that we would be losing healthcare workers if they weren't fully protected during code blues with COVID patients. Again, now we know that there's little transmission from fomites. Again, at the beginning, we were very concerned about what equipment we brought into the room, how we cleaned the equipment when it came out. Less concerned about that now. We're focusing more on aerosols and more than anything else, and less so on respiratory droplets, and certainly less so on fomites. The data to present suggests that there's very low risk to chest compressor. So there has not been a significant number of documented cases where somebody doing chest compressions has contracted COVID from that basis. So they're now making a recommendation that you do not delay chest compressions for witness cardiac arrest if the patient is COVID confirmed or suspected. The initial compressor does not necessarily need to wear a surgical mask, but should place one as soon as possible. And you don't need to place a surgical mask over the patient, but you should try to do so as soon as possible. And you continue your compression until you're relieved by somebody with full PPE. So those are the recommendations. Again, one of the difficulties with the MUHC protected code blue protocol is the nurses on the floor had a lot of moral distress, because what they were being told and what they're still being told is that they should not go into the room unless they have full PPE, and they're supposed to delay chest compressions until the code team arrives and prioritize both intubation but primarily defibrillation before you do anything else. So again, these guidelines or these recommendations coming out would be a change from our current practice, and we'll see if we do decide to change it. Again, the Omicron thing makes it seem that we would have to wait for another couple months at least to see what's going on. So we'll continue on at the MHC with our current practices. They're also stating that you should consider mechanical CPR for obvious reasons. And again, anybody coming into the arrest, it should be communicated clearly that they need to be in PPE before that. So again, the recommendations are still defibrillate as soon as possible, but now don't delay for PPE to be placed on. And it takes at least 2 minutes realistically to get everybody in PPE appropriately. If there's agonal breathing, you can consider passive oxygenation, apneic oxygenation, until a HEPA filtered ventilation can be provided. You put a HEPA filter on any ventilation device. If you are going to be bagging the patient, if you feel that's necessary while you're waiting for an LMA or an endotracheal tube, it should really be a two-person technique, and one person really should be assigned to make sure that the face mask seal is tight as possible with a HEPA filter on the bag. And again, recommending a supraglottic device or an endotracheal tube as soon as possible. Again, the intubator with the highest chance of first pass success should be used, and you consider video laryngoscopy. They asked and answered a series of questions, and again, here's the evidence for it. You can see that it's not overly strong, but the first question was, is masking the patient during initial chest compressions necessary? And they're saying no, based on the fact that studies done, some of them from Peter Safar back in the 50s and early 60s. Peter Safar is the grandfather, the father of modern resuscitation, for those of you who haven't heard of him. So he demonstrated that tidal volume is very, very low in an arrest situation, and usually the airway is obstructed by the tongue. So there's almost no airflow unless you're trying to, unless you purposely try to keep the airway open by one device or another. So based on that, they say do not delay chest compressions. Apply surgical masks once it's nearby. The second question is, do first responders need to don masks for their safety? So again, no reports of chest compression alone on COVID positive patients resulting in healthcare worker infection, and do not delay initiation of chest compressions. There's a negligible risk to vaccinated healthcare workers performing brief compressions. However, again, for COVID and for most pediatric and neonatal arrests, usually ventilation and oxygenation is the priority. There's a difference between a primary arrhythmogenic arrest, in which case you had generally a normal oxygenation status for the patient just before the arrhythmia started, and therefore you have a reserve of oxygen for a long period, or for minutes at least afterwards, versus somebody like a kid or somebody with COVID whose most likely reason for the arrest is going to be asphyxial or hypoxemic. In that case, your ventilation should be given a much higher priority than the arrhythmogenic arrest. Are intubation boxes useful? They don't know. They don't recommend them. Do mechanical compression devices help during resuscitation? So it clearly reduces the number of persons required in the room. And again, with aerosols being generated in the room, you want as few people there as possible. It does help to maintain quality compressions. There's no evidence that it's superior to manual compressions in survival to discharge with intact neurologic function. But again, all of those studies that compared standard manual compressions to mechanical CPR were done with paramedics who were trained to give high performance compressions. And I'm not sure that's the usual practice in most hospitals in the world. So I would think that the Lucas device or the mechanical compressors are preferred strongly in this sort of situation. Okay, so that's the update on protected code blue or COVID code blues. Does anyone have any particular questions about that in the chat? I don't see my chat box up here, so.
There's no question currently.
Good.
Seems like you're very clear.
Clear, good. Continue doing what we're doing. We'll see what happens in January, February. So the American Heart Association, the European Resuscitation Council, and the International Liaison Committee on Resuscitation, before they were putting out an update or a new protocols every 5 to 7 years, and they realized that that was too long a time, given that science hopefully advances more rapidly in that. So over the last multiple years, they've been putting out a yearly consensus on the science of CPR with treatment recommendations changing if the science warranted that. So now I'm just going to pick a few topics from the 2020 and 2021 updates. The 2021 updates were heavily emphasized neonates and pediatrics, and a lot on drowning and special circumstances like that. There really wasn't that much new for standard CPR. So that's partly why 2020 as well. So if you're looking at some of the top topics that are relevant from the 2021, they do make some comments on head-up CPR, which we'll get into. They talk about, they try to clarify the emergency post-arrest need for a coronary angiogram, and don't really clarify it that much. Basically saying there's not a change in the science or in the evidence base. But basically, if it's a STEMI, you should highly consider going to the cath lab. If it's a non-STEMI, you could go early or late or not at all, depending on judgment. And then because of the COVID situation, they make a special statement on what to do if somebody arrests when they're prone, in the prone position. And basically, if you're prone with an endotracheal tube in place, you should start chest compressions in the prone position. In other words, you're compressing from the posterior until you have a team in place with proper PPE in place, and that allows you to deprone the patient. I don't know if any of you have seen proning and deproning, but it's a 5 to 7 person technique to do this safely without pulling out an endotracheal tube or a central line or an art line or things like that. So that's fine if you're intubated. If you're not intubated, meaning that this patient was self-proning and they're on Optiflow or BiPAP or something like that, then they should be flipped over as quickly as possible and CPR run in the standard fashion. So those are the three sort of major things from the 2021. So this is heads up CPR. And you can see the Palm Beach County Fire Rescue Service has adopted this protocol. And there are many or several EMS services in the United States and elsewhere that are now started doing this as a routine. So why would they be doing this? Again, this is not a settled thing. It's an area of increasing interest and debate. But the idea is, and this has been proven in pig models. So for pigs, there's no question that it will increase venous return from the brain, decrease ICP, improve cerebral perfusion pressure. And also the chest compressions themselves lead to a sort of a concussive or percussive transmission of pressure, both in the veins and the arteries to the brain. And they're thinking that that might be harmful to some degree, that decreases those sort of percussive or concussive forces. So that was the physiologic rationale for trying heads up CPR. But however, so far there's only one observational before and after study, and it wasn't just head up CPR, it was bundled with a mechanical chest compression device and an impedance device trying to improve interthoracic pressure swings as well. So based on that, they suggest against the routine use of head up CPR, a weak recommendation with low quality, very low quality evidence base. And they're suggesting further clinical trials. And they're pointing out the obvious knowledge gaps that we have at this point in time. So I think this is an area of interest and something that you would follow, but I don't think if I was urgent santé that I would change my practice a bit yet, nor should we change our practice in the hospital, in the emergency department or the hospital. So that's head up CPR. And then they also in 2020 have a section on defibrillation strategies for VF or pulseless VT. So the question that they're looking at with a scoping review was whether there is a benefit of anticipatory defibrillation charging versus the standard approach. So the idea is to try to minimize peri-shock interruptions and chest compressions as much as possible. It's clear that the time, the duty cycle time that you have, not the duty cycle time, the chest compression fraction time is very important in terms of the quality of CPR. The American Heart Association recommends at least 80% of the time chest compression should be given. Really, I think you should be aiming more for 90 to 95% of the time. And then so you're looking for strategies to try to decrease the hands-off time during CPR. So in the standard fashion that's been recommended, you're supposed to pause every 2 minutes for a rhythm analysis. And then if the rhythm is deemed to be shockable, then you're supposed to resume compressions, charge the defibrillator, stop compressions and shock, and then restart chest compressions. The anticipatory mode means that it's getting to 1 minute and 45 seconds, you charge the defibrillator at that point in time while chest compressions are still ongoing. Then you stop the chest compressions when the defibrillator is fully charged. You do the rhythm analysis. If it's a shockable rhythm, you shock at that point, and then you start chest compressions before. So that's the difference between the two. There's no clinical studies in a randomized fashion or unrandomized fashion that really address this in a neurologic outcome fashion, which would be the gold standard for it. You have some mannequin studies and one retrospective unit study, and it's sort of a mixed bag, although it reduces overall pause duration and does increase the chest compression fraction overall. The actual pauses that you have are a bit longer because now you're pausing, then you're shocking, and then you're pausing, then you're analyzing, then shocking, then restarting. So at this point in time, they give no treatment recommendation in the absence of sufficient evidence. I think for hospitals, it would be best if the system, the emergency department or the hospital itself decides to go one way or the other, so we have a standardized approach. I think that's probably the more important thing in this situation. Personally, I prefer the pre-charging the defibrillator mode. Now, they also went on to double sequential defibrillation with a systematic review in 2020. So 20% of patients with ventricular fibrillation refractory to shock ×3. So they're calling shock refractory ventricular fibrillation as failure to convert after 3 shocks. In the literature, there's a lot of the definitions are 5 shocks. So somewhere between 3 and 5 shocks, you should go into your mind that this is a shock refractory ventricular fibrillation. And then there is a new algorithm that opens up at this point in time, or decision points that open up at this time. So the refractory, but they're still in VFib or a pulses VTAC. They only, of course, have observational studies so far with a high risk of bias. There's a significant heterogeneity amongst the studies, and there's no consensus standardized approach to double sequential defibrillation to begin with. They tried to do a meta-analysis, but didn't have the data or couldn't find the data. There was one pilot RCT that was done, which really just demonstrated feasibility. And there's a larger ongoing randomized controlled trial, which hopefully will have some results in the next 2 or 3 years. So at the moment, their treatment recommendation is against the routine use. And they want you to focus on making sure you deliver the maximum amount of energy with the minimal impedance and the optimal vector. So that's what this is just double sequential or dual sequential defibrillation for those of you who haven't seen it before. So you're placing the pads in the usual anterior lateral and anterior posterior positions, and then you're supposed to be shocking using 2 defibrillators and pushing the button at the exact same time. Again, just another diagram or cartoon demonstrating the positions, but there would be 1 defibrillator off to the right of the patient, 1 to the left, and 2 people with their fingers on the button, and then you have to decide whether you go 1, 2, 3 shock or 1, 2, 3 or something, but somehow you coordinate the shocks between the 2. So why would this work? Why might this potentially work? So in terms of defibrillation, if you're getting a shock resistant situation, whether it's cardioverting atrial fibrillation or ventricular or defibrillating VFib, you need to have 95% of the heart has to be depolarized for successful defibrillation. That means that the pad placement is very, very important, and the vector between the 2 pads is very important. Again, we've gone from a paddle model in this hospital for the most part to the sticky pads that are placed on the chest. I'm not sure that's for the best. It's for the best if you have a prolonged resuscitation. But the advantages of having the paddles in place is that it allows you to change the vector much more easily if you think that may be the problem. It also allows you to put more pressure on it if you think that there is a problem with the application of the pad or the paddle onto the patient's skin. It also allows you to put more pressure down to empty the lungs completely so that you get the least impedance as possible. So I would say if you get into a situation where the patient is not responding to electricity but still has a shockable rhythm, the first thing you should check to see is where the pads are placed and try to determine whether the vector is favorable for 95% of the current going through the heart. Remember, when an arrest happens, there's usually a lot of activity going on, and somebody is trying to reach usually under somebody else, trying to get the pads in the right place. They don't always get the correct location the first time. So that's just in terms of the vector and the position of the pads. The second issue is impedance. And there was actually paramedics in Ontario were sued by a family. They were called to an out-of-hospital arrest with a 47-year-old, I think, and they documented well in their note that they had significant problems attaching the pads because the patient was morbidly obese, extremely diaphoretic, and very, very hairy. And so there was a significant delay in getting a shock to him because of all of those challenges. And then, unfortunately, they documented that well in their note, and the family took it on them that they did something incorrect and actually sued them. I don't know what the outcome of the case was, but the lesson is that you need to, again, if the patient is very diaphoretic, you have to get towels and dry them up as much as possible. If there's a lot of hair on the chest, then you have to try to, as quickly as possible, shave that off. And then the contact between the pads and the patient's skin is very, very important. If you're not getting a good contact with the pads, the sticky pads, I'd recommend you go to the traditional paddle model. The other thing is that often just before you do your about to shock, or when you call the chest compressions off, the RTs sometimes like to give just like one more breath at that point in time. You really want the lungs as empty as possible for this to occur appropriately. So again, refractory VFib, VTAC, electrical storm, traditionally has been 5 shocks in the literature. I just see that the last ILCO LCOR document says 3 shocks, but you know, it's the same. Your options once you get into this situation are, sure, you can try double sequential defibrillation, beta blocker with esmolol. If the patient was a witness arrest, has the usual indications and doesn't have any contraindications, certainly at the MUHC, a code ECMO should be called. The last option would just be leaving him on the Lucas device and proceeding directly to the cath lab with chest compressions ongoing mechanically. So I'll talk a little bit about antidysrhythmics here. These are the pre-hospital studies with antidysrhythmics. So as you would expect, none of them have demonstrated a clear survival benefit. Certainly not a survival benefit with good neurologic outcome. There's a couple of studies. The first one at the top here, Kudenchuk's first study, demonstrated with amiodarone more ROSC in the pre-hospital situation, but again, later on, not much. And the last study, again, was Kudenchuk's ALP study that showed both amiodarone and lidocaine did lead to an increased incidence of ROSC. There certainly wasn't enough data to say that one is superior to the other. Again, no evidence for higher level survival as of yet. So they are suggesting that you use either amiodarone or lidocaine in adults with shock refractory VFib or pulsus VTAC. That's a weak recommendation with low quality evidence. They suggest against the routine use of magnesium in shock refractory ventricular fibrillation. The exception would be if you thought Torsades de Pointes was possible. And they say that for any other antidysrhythmic, so beryllium, I can't even pronounce pronounced Nefencalant. It's not available in Canada as far as I know. And Sodalol, there's just not enough evidence for it. And there's also no evidence to support or refute a recommendation for prophylactic antidysrhythmics immediately after ROSC. So often we have somebody who has VFib, they get resuscitated, they're in sinus rhythm, and the question is whether we should be starting them on antidysrhythmics. There really is not enough of a science, at least in terms of clinical studies, to guide you in those type of decisions. So why esmolol or why beta blockers? Well, we use beta blockers frequently, well, not frequently, we use it about like 2, 3, 4 times a year in the ICU when we have somebody who has a recurrent ventricular fibrillation. So sometimes we have these patients that go into VFib 10, 20, 30 times a day. And usually they tried lidocaine, you've tried amiodarone, you've tried other of the standard antidysrhythmics. Beta blockers are very good antidysrhythmics, and they work very effectively against ventricular fibrillation. The mechanism is not quite sorted out, but there's no question that they work. And I don't think I have seen a patient who's failed the other ones where a beta blocker hasn't had a significant effect. The challenge with the beta blocker has always been that you have somebody with a limited cardiac reserve, and you're trying to, you're giving them a beta blocker that's going to further depress cardiac output. But in terms of the rhythm, the ventricular fibrillation, they clearly can stabilize that. So based on that, there's these 2 studies that used esmolol for refractory ventricular fibrillation. And again, case control, retrospective, but demonstrating, at least finding a signal for potential benefit. So if you were so inclined, the dose would be 500 mics per kilogram of esmolol as a bolus. So we'll leave the antidysrhythmics now. Take a pause. Any questions coming up in the chat, or is this just flowing just so smoothly and so clear? No questions.
There are a few questions in the
good.
chats.
Yeah, so I can go through them. That's okay. Yeah, whichever. So there were a few that came up. I'm just scrolling to the top. So first, thoughts on any solutions to the timing of placement of mechanical device during code to avoid long pause. What are acceptable delays versus continuing with manual compressions?
I think it really comes down to team training. I have not seen significant delays at the MUHC with the device being put on place. You start chest compressions ahead of time, and you can place the mechanical device with minimal pause if you know what you're doing. The code blue nurses practice this regularly. So I think that's the key thing is team training and practice. I still think that, again, and this is based on looking at the quality of chest compressions at the MUHC or last 20, 25 years, that mechanical devices in our setting are far superior, both in terms of starting CPR and the quality of CPR. And in terms of the team training, it takes a lot less team training to do this than standard chest compressions. Before, in the emergency department, the chest compressions were usually delegated to the orderlies. And I must say, the chest compressions were very variable in that setting. One of the challenges would be trying to keep the maintenance of skill up for the orderlies to do standard chest compressions. Yeah, I don't think it was well done before. So at least in my opinion, this is my opinion, the addition of the mechanical devices has improved the duration of the amount of chest, the quality of chest compressions, and has increased significantly the chest compression fraction versus what was done before. That was the point I was trying to make when you're comparing mechanical chest compressions to standard chest compressions. All those studies were done with paramedics who are really drilled and drilled and drilled in terms of how to do this properly. And again, in a hospital setting, it's not always possible to do that. Next question. Hopefully that answered it.
Yeah. So next from Dr. Myers is, if you want to try the paddles, is it necessary to remove the pads first, or can you shock over them?
Don't know. I would say yes. Don't know. I don't think there has to be some insulation on the top of the pad, so to guard against other people getting shocked. So I think you should be removing them. Yes.
Okay, and then comment from Dr. Deschamplain was just talking about so reports from Toronto EMS that they're doing one shock right before the other, as if you push exactly at the same time, you can bust one of the defib machines. That's the comment.
Okay.
Just talking about that. Yeah.
I think the chance of two people pushing exactly the same time is vanishingly small, but okay.
Yeah. So the manufacturer actually had a series of when, especially in Toronto, where they're running the randomized controlled trial in EMS. They had a bunch. I spoke with Sheldon Cheskes, which is the PI of that study, and initially they were doing it at 2 operator, pressing both machines, and they had a couple, and there's been other reports. So, and the manufacturers, really discouraged this technique. It's not on warranty, and so the idea is that the energy goes from one wire and goes up the other one all the way back and busts the circuit. There's a short essentially, and the AD apparently is not repairable or not easily repairable afterwards. So what they've done is that there's a single operator. So he operates the 2 machine, and he essentially push shock on defib A and then shock on defib B, and he's trying to do this as fast as he can. But obviously there will be a few milliseconds or probably a second between the 2.
Okay.
And they haven't had any issues since.
Okay.
If you try this in the hospital, you may not want to bust like a $30,000 monitor defibrillator on your first attempt. That may not be great, but I don't know. It's not reporting exactly the exact incidence of that, but there's multiple reports.
Yeah, again, it comes back to the question of why would double sequential defibrillation work. One possibility is that you're just giving double the dose of electricity. That seems to be less likely, and I think really the vector. So you're sure you're more likely to polarize 95% of the heart, and the impedance are 2 of the reasons why it will work. So I think if you don't want to go to that, just remember to focus on those 2 issues with standard defibrillation. Any other questions? Or
no, there were a couple more. One was from Dr. Myers asking if you specifically use antidysrhythmics after ROSC.
Usually there's a big debate about it, and I would say I do. I'm not sure I'm consistent 100% of the time. If I think I have a clear inciting event that has recovered from, then I don't. But yeah, no, I think most of the time I would.
Alrighty, and finally from Dr. Ryder, are any updates on look-through monitors?
Yeah, there is an update that I looked at closely. I didn't include it in here. They basically said it's not ready for prime time. Now, they haven't made a firm recommendation on it one way or the other. Again, these documents are very evidence-based, so they only make the recommendation usually unless there's some degree of evidence. But at this point in time, they did not make a comment positive or negative for them.
All right, thanks. That's the end of the list for now.
Okay, so moving on, we're going to talk briefly about airway management during cardiac arrest. So the PART study, which was published in 2018, again with paramedics, and it was just LMAs versus endotracheal tube, had a signal at least to improved ROSC and maybe some improved survival, although it didn't reach significance at that point, in paramedic systems and patients who got LMAs as opposed to endotracheal tubes. They're suggesting that that during CPR, you can either use a bag valve mask or an advanced airway in any setting, both hospital or pre-hospital. Again, weak recommendation, low to moderate certainty or evidence for it. If you are going to use an advanced airway, then the recommendations is you can use either a supraglottic device or a endotracheal tube. Supraglottic devices should be prioritized in systems where the paramedics have a low experience or low yearly incidence of endotracheal intubations. And if you have you happen to be in a system where there are paramedics that do have more exposure and have demonstrated to have high endotracheal tube success, then they could consider an endotracheal tube. So that's where you're at for it. For the in-hospital cardiac arrest, they say you can use either or, weak to very low evidence, weak recommendation for very low evidence. So at this point in time, based on that, there's certainly no reason for Urgence Santé to change their current approach with combi tubes in the field. And again, in the emergency department, I would just keep in mind that an LMA is a acceptable way to manage these airways, particularly if you're talking about COVID patients. Again, you would like to get the airway sealed as quickly as possible. It's an option at this point in time. And why are these recommendations? So this is a famous paper from 2015. This is in-hospital cardiac arrest. And again, the arrest teams are usually not made up of people who have expert intubation skills. They demonstrated that you had versus patients where they did not intubate for the first 15 minutes. Patients who were intubated earlier had a more prolonged interruption of chest compressions. And again, I think really you should be able, ideally people should be able to intubate these patients without interrupting chest compressions. It does require a higher level skill, but that's the level of skill that we should be aiming for. There's also a delay of defibrillation, the delay of other interventions, hyperventilation with a decrease in venous return, hyperoxia, which may be detrimental, and unrecognized esophageal intubations. So based on this paper, certainly in the MUHC or most hospitals would state that the code teams, the priority for arrhythmogenic cardiac arrest, and again, I differentiate arrhythmogenic from asphyxial or hypoxemic arrest, that you can just go with bagging and avoid chest compressions early on. The goal, remember, when you're managing the airway is to provide sufficient oxygen to the blood without impeding perfusion. You should be cognizant of the negative effects of positive pressure ventilation during CPR. It reduces venous return and therefore reduces coronary perfusion pressure. Both are bad things. It increases or decreases the chest compression fraction. And excessive ventilation is common during resus environments. I must say I pay attention to the RTs in our hospital, and they're actually quite good at bagging only 8 to 10 per minute. But there's been multiple studies in the paramedic literature demonstrating that well-trained paramedics in stress situations bag at a rate of 28 to 30. Remember, in a stress situation, time perception is often lost. So as a code leader, if the patient is being bagged, you should be paying attention to the person doing the bagging to make sure that they're, one, not overinflating, two, that's going to decrease venous return and cause potentially alkalosis, and two, that they're making sure that the patient is not excessively overinflated. In terms of confirmation of endotracheal tube placement, again, the strong recommendation now is that waveform capnography should be used to confirm position for all intubations during CPR. So all of the other methods are considered to be suboptimal at this point in time, but if that's all you have, that's what you should do. But as a hospital system and an emergency department, we should have it routine that waveform capnography is placed immediately to confirm tube position. I'll talk about waveform capnography in a minute for physiologic monitoring. In terms of automatic ventilation during CPR, my preference now is to place, once they're intubated, to place all patients on a ventilator. And you just defeat the pressure alarm on the ventilator, put the PEEP at 0 or 5, put the patient at 100%, and ventilate them at about 8 per minute with a tidal volume of about 400. And what that does is that, again, you have the patient on the Lucas device, you have the patient on the ventilator. It quiets the room out significantly and allows everybody to focus on it cognitively offloads the entire room, allows you to focus on other things. Now, this can only be done with the transport ventilators. I've tried to do it multiple times with the ventilators in the intensive care unit. Unfortunately, they're too sensitive with the chest compressions and they keep being triggered. So basically you get a breath with every chest compression and that's not good. But for these prolonged arrests that we're running, especially when we call a code ECMO, putting the patient on the ventilator, as long as it's set up appropriately and the ventilator doesn't get over triggered by the chest compressions, has some advantages. The last thing I think I'll talk about, because time is running out, is physiologic monitoring during CPR. So the ability to monitor physiological variables and tailor your resuscitation interventions to precise physiologic states is very appealing. In other words, why should it be different if somebody is in a PEA arrest versus somebody's severely hypotensive in the ICU in terms of the degree of physiologic monitoring and the physiologic endpoints? The idea is that you'd be resuscitating on an individualized basis until you hit a specific target, whatever your physiologic output endpoint is. So your options at this point in time are end-tidal CO2, arterial blood pressure monitoring, and NIRS if you have that available. We don't have that here for brain saturation or brain perfusion monitoring. And this concept was first published or first endorsed, I guess, by the AHA in this document from 2013, where they stated that for in-hospital arrests, certainly in a monitored setting, that you should be aiming or considering using physiologic monitoring. My computer is not advancing now. I'm not sure why. Here we go. Again, this is a paper from Meany, which was mainly from the pediatric large database they have across North America. And they just did a retrospective study demonstrating that pediatric patients who had dual or triple level physiologic monitoring, in other words, a CVP, aortic diastolic pressure with calculation of the coronary perfusion pressure, and end-tidal CO2, had more successful resuscitation than those that didn't. So again, trying to improve the quality of CPR by optimizing chest compressions, parameters, or giving vasopressors, or both. In other words, what you're trying to do is you're looking for a particular physiologic target. And if you're not reaching that physiologic target and you haven't got return of spontaneous circulation yet, you would try to optimize something to reach that physiologic target. If it's a coronary perfusion pressure, again, it's been demonstrated coronary perfusion pressure of greater than 20 is usually necessary in order for the patient to respond appropriately to defibrillation. In other words, if you're less than 20, maybe you shouldn't even try to defibrillate yet. That would be the theory, that you should optimize your chest compressions further or give epinephrine to raise the coronary perfusion pressure. If you're just have an aortic line and you're looking at the diastolic pressure, then there's a diastolic pressure of 25. And if you have end-tidal CO2, it should be an end-tidal CO2 greater than 20. I'll skip that for the moment, just in terms of time.
Dr. Melanson, there was a question from Dr. Namath about TEE. Do you have thoughts on that for monitoring?
Oh yeah, well, again, all of these things that we've talked about, look through and TEE and end-tidal CO2 and monitoring, are not new concepts. I remember when I was a R1 resident, my first ACEP conference, I went to a CPR symposium given by Henry Ford Hospital with a young Manny Rivers and Norm Paradis and people like that. And they were using esophageal, they were using transesophageal echocardiography at that time to guide the resuscitation methods. So I think it is something that is certainly an area of interest and an area of investigation. For the purpose of these updates, so the American Heart Association or the ALCORT had no comments about it in either in 2020 or 2021. But yes, there's a lot of reasons theoretically why that would be yet another monitoring device that you could use. So just getting back to end-tidal CO2, this is how it could help you. So this is an actual patient, and you see that the end-tidal CO2 is less than 20. At this point in time, CPR is done. Then they do something around here, and it's not clear. It's been a while since I looked at the slide. They either gave epinephrine or they changed their chest compressions and got the end-tidal CO2 up to around 20, shocked, and then you can see the huge increase in end-tidal CO2, which would indicate that you have ROSC. So that's how end-tidal CO2 might guide you. Anyway, so what their recommendations are, and again, this is based on the scientific support or evidence they have right now. They make no treatment recommendations for any particular physiologic measure to guide CPR because the available evidence would make any estimate of effect speculative. So again, this is something innovative and investigational. It's not for the masses yet. How much time do I got left now? 2 minutes. Let me just talk about vasopressors very quickly. Make it very straightforward. So they recommend still, strongly recommend still, that epinephrine be used during CPR, low to moderate evidence. Certainly if you have a non-shockable rhythm, epinephrine should be given as soon as possible. If it's a shockable rhythm, they recommend that epinephrine only be given after at least one unsuccessful attempt at electricity. They suggest that you don't use vasopressin, either in the place of epinephrine or in addition to vasopressin. Both of those are weak recommendations with very low quality evidence. I think I'm going to stop here. I mean, there's basically, these are the studies that the recommendations are based on. Epinephrine has both positive and negative effects, and the concerns are the negative effects in terms of increasing myocardial oxygen consumption, increased post-resuscitation myocardial dysfunction, increased ventricular dysrhythmias, myocardial necrosis, and it may also negatively impact microcirculation at the brain level. So you can, then I'm on to bradycardia. So not bad. I got through most of what I wanted to. I didn't think I'd get through everything. I think I'll stop here and ask maybe one more question because I have 1 minute left.
No, that's super great. Last question from the list from Dr. Mayers is just using Lucas, does it have settings that we can change to optimize compressions, like faster or pushing harder? Does it only do it in one way?
It only does it in one way. So it's really a matter of making sure it's located appropriately. So the problem with the Lucas is generally just like the same as putting on the pads, that you may not, in a rush situation, your first attempt may not be optimal. So you should look at repositioning things, and you may have to stop it and seat it back down. You have to seat it appropriately on the skin level before you press the start button.
Okay. All right. Well, that was great. Thank you, Dr. Melanson, for doing that.
Okay.
Great presentation. Always great to hear from you. Thank you.
My pleasure. Thanks.
Okay. So next up, final presentation of the morning is Dr. Tyler Safran. So this is our very nice plastic surgery resident who we see around, at the hospital a lot. So without further ado, go ahead, Tyler.
Can you guys hear me okay? Is it I'm in the office. I don't know if it
I can hear you well, and I can see, yeah, you're in presentation mode now.
Perfect. So hello everybody. Thank you for having me back. It's a pleasure to be here. I'm gonna go through basically what they asked. Last time I gave a presentation was on almost like a hand exclusive talk. And it seemed to be, people seem to like it. So what I did today is I kind of used similar concepts, but I kind of did it for everything that we would see normally in the emerge. I have also, 30 minutes, right, till 11:50? Okay, so I have a lot of material also to cover. I'm grateful after hearing the last 10 minutes of the last talk. I'm grateful I don't have to run any more codes in my life, but this stuff's pretty exciting too, in my opinion. So without further ado. So the first thing that I always like to talk about is the emergencies in plastics. So the overall theme is basically how to manage the case before or during the call to plastic surgery. Because sometimes, as you know, you call and we're kind of like, wow, we don't want to come in, or we don't want to, we're kind of asking for further studies before we come in and stuff like that. So that's basically the overall topic. And these are really the emergencies that we see in plastics. And we don't see many things that we have to run in for, but these are typically the things that I'm like running out of bed quickly to the emergency room. So the first, and we're not going to go into these because I think you guys cover these quite a bit. So neck fash, the only thing with neck fash is there was a case recently, and we discussed this in our own M&Ms, and I always think it's important to bring it up, is because Gen Surg is supposed to be the triage team. So we always say, call Gen Surg first. However, what we should be doing is that if we know that it's a neck fash or a suspected neck fash in the upper limb, why do we need to get Gen Surg to then call us? So it should be maybe a call to Gen Surg and then a call back, and then a call back to the call to us to come. And we should be there at the same time to do our assessment. Then if we're on face, obviously face. For compartment syndrome, devascularized limb. So there is a replant center, but however, if there is something there's a question, or you're at a peripheral hospital, calling plastics to come assess the patient is not a bad idea. It's actually the right thing, because then we could liaise with the team over there, and sometimes some of our staff will actually take the case here. Burns. So we have the children's is our burn center. I know you guys aren't, I don't think there's any peds here, but in terms of other burns, major burns, just to know that there is the burn center that covers all burn criteria for transfer. And then the last thing, we have airway compromise, obviously, major arterial bleeding and nerve, and then entrapment. So when it comes to orbital floors, but just always making sure that ophthalmology is involved as well at the time of consultation. So the first thing is always the thing that I go over is the hand exam. So when you're examining any hand, it's always important to get ID, their age, what do they do? Is it a CSST case? Because that really guides a lot of our treatment protocols. What was the mechanism? Do they have any medications? Are they on anticoagulants? That comes important if we're going to book them for trauma. What's their social history? Are they a smoker? What's their tetanus status? These are the tetanus recommendations. I'm not going to go into them today. I did last time. And then the evolution of what's happening. So a lot of times we get called that patient has a laceration and they have a decrease in sensation, but it's possible, and we've seen this before, where they've had that decrease in sensation for a very long time because they've had an underlying carpal tunnel syndrome, for example, and that's actually what led them to cut themselves because they weren't aware of what exactly was happening with their hand. That's an obviously extreme example, but it's important to get that history and not always to assume that it's an acute nerve laceration. And then when you always do a physical exam, and I am a victim of this myself, it's always important to compare to the other hand. And that's because when it comes to scissoring, and which we'll get into, and other focal examination findings, it's sometimes very common that we see these on the other hand as well. So the things I look at is first I look at the hand overall. So inspection, is there erythema? Is there obvious pus? Is there a laceration? What's the hand cascade? Does the hand look perfused? Then I palpate. Is there any fluctuance, obvious deformity? Could they bend their finger actively? Could they bend it passively? And then always get perfusion if there's a laceration, not only medical legally, but it's very important in terms of figuring out if we have to do something stat or we could wait till the morning. So for all those who don't know, when I say cascade, this is the normal cascade. So when the hand is completely relaxed, it always goes into a somewhat of a cascade. And that's because it's, if you think about it, the muscle bellies are all in the forearm. And what happens is when we put stretch on the wrist, it pulls on the tendons at different lengths. Their excursions are different. And that's what gives you that cascade. And we use this a lot to test. So if you want to see if a patient, for example, has a laceration and they're intubated and they're unable to and they're sedated or whatever, you could actually passively flex and extend the wrist, and you'll see that you're able to get a tenodesis effect, which is basically to see if there's a normal cascade. So that's one exam you can do. The next thing is when we get called a lot about hand fractures. So we typically will go into, we don't come to see closed hand fractures in the emergency room because there's not much that's going to change. You guys are so good at doing reductions that if you're not able to reduce the fracture, the chances of us reducing it is very low. And the main things to look for on any hand exam is if there's scissoring, which you can see here. But it's super important that you compare it to the other hand, because oftentimes patients that have a fracture that you wouldn't expect there to be scissoring, they're actually scissoring on the other hand too. So it's not something that we actually have to intervene about. Shortening, so I always get the patients to go like this. And then the last thing is extensor lag. So you would see that they actually lag their finger down, and that's just basically the excursion of the tendons is different because of the pull of the fractured segments. When you're looking at a hand x-ray, in my opinion, every patient that has a hand complaint should get a hand x-ray because it's a very low cost procedure. It's low radiation, and it's very relevant, especially if you're talking about foreign bodies, fractures, or ligament instability. And sometimes it just helps us rule out something else. So what to prepare before you call? So always knowing the mechanism of action. So crush, laceration, foosh, smoking status, type of fracture, physical exam, etc. Because that basically will say, you know, if it's a patient that's a heavy smoker that has a boxer's fracture a week ago, they're much more likely to be able to be reduced in the emergency room than someone who's a very healthy young patient who had a boxer's in the same time frame. So it also changes the way that we see these patients as well. And your physical exam will really dictate when we have to see the patient and follow up. For example, a boxer's fracture that was attempted reduction, you felt like you got a good reduction, you see it on the x-ray, but they're still scissoring, will have to be seen sooner than a patient that has never been scissoring and never been reduced. So that's another important factor for us. When would we need to see a fracture? So if there's a neurovascular status change. So let's say, and I've seen this before, especially when it comes to in the pediatric population. So I was on call one night and I got a call saying that the patient had a fracture. It was a proximal phalanx fracture, and they had neurovascular compromise. And as usual, you know, we're always like, well, you know, like, are you sure, whatever. But when they put the saturation probe, they were unable to get a saturation of the digit. And what ended up happening was a transverse fracture of the proximal phalanx, and there was a translocation of the fractured segment, and it actually put stretch on the neurovascular bundle. And so this was, we had to bring the patient emergently to surgery. There was no actual laceration, but just that stretch put the finger into spasm. So it's very important to always check the neurovasc of your hands, especially if you're doing a reduction. So pre and post reduction. Open fractures, again, it's not like it's an open humerus fracture. It's really just like an open phalanx fracture or something, unless that the phalanx is sticking out at you. Most of the time what we do is we irrigate it really well and close the skin, and I'll show you some examples of that. And again, always document if there's a tendon or especially at that, because some of the bony edges could actually lacerate the extensor tendons as well, especially in a metacarpal fracture. An irreducible dislocation, that's important because that can lead to a lot of problems later on, but it's something that has to be discussed because it could be the actual dislocation pattern itself that's not amenable to our traditional reduction techniques and amputations. And the one thing that I get called often about is, they do a reduction and it's still unstable. And that's because these types of fractures, so there's a bunch of them, but these are the classics that we're going to see. So the spiral metacarpal fracture, the transverse metacarpal fracture, the bicondylar or the unicondylar proximal phalanx fractures. The proximal phalanx is one of those bones that almost, regardless of how you fracture, you're going to end up with a ton of problems. But these types of fractures are very unstable and they traditionally require operative fixation. And even if they don't, they're coming to see us once a week for a repeat x-rays to make sure it hasn't moved. So even if you reduce these, you might put them into a better position, but it's very hard to maintain traction in your splint. So they're traditionally going to require surgery. When you do your reduction, one thing that I started to do a lot more is we were always doing hematoma block, but I started doing a lot more regional blocks. So for boxer's fractures, I'll do an ulnar nerve block. Sometimes I'll even, depending on where it is, I'll do a median nerve block at the same time. I'm not sure how your billing codes work, but for us, it's also quite good. And at the same time, it's a great way for the patient because it's really one injection away from the hand. So it's distal to the hand, or sorry, proximal to the hand. And as a result of that, it's actually less painful to the patient. So for the ulnar nerve block, I palpate FCU and I go right underneath it. And then that the nerve is followed by the artery. So as long as you withdraw and you don't get any blood, if you just infiltrate under the FCU tendon, you're going to be able to get a good ulnar nerve distribution. For the median nerve, I always go ulnar to palmaris longus. I know this isn't covered in the talk, but just to say. Then I always go just proximal to the wrist crease. And then you really tell the patient not to move if they feel any pins and needles in the fingers. And I just go at a 45-degree angle. You usually feel a little bit of a pop. You're underneath the transverse carpal ligament. I withdraw and infiltrate. And then for the radial nerve, I just do a subcutaneous wheel or a bleb all the way across the dorsum of the hand. And that way I get really good anesthesia when it comes to reductions. So two common reduction techniques. So for the traditional boxer's fracture, we use the Joss technique, which basically utilizes the proximal phalanx to push upwards as a lever, and then you push down on the metacarpal. So the proximal phalanx goes up, pushes on the head of the metacarpal, and then while pushing down on the metacarpal, you really get that clunk, because most of the time it's apex dorsal, and so you really want to make sure that they come together properly. This is a Bennett fracture. Now, I don't know, we don't traditionally reduce them in the emergency room. This is more of an operative reduction, but it's possible if you guys see this, especially in the community where no plasties is around. It's a classic traction, pronation, and pressure at the metacarpal base to get that little fragment back. Because this ligament here is called the volar beak ligament, and it's very strong. And so you really want to bring the metacarpal towards the osseous fragment as opposed to bringing the fragment to the bone. So that's how we do that. So when it comes to ligamentous instability, there's basically a bunch of joints. Now, these are the slides from my last talk, but I thought it was important to really go over them again. So when you have a reduction of, a dislocation, the one thing you want to check after it's reduced is active and passive stability. And so when you reduce a dislocation, it's very important to assess that, because if it's consistently dislocating, you need to let us know so that we see it sooner, because that's a problem. If you put them into a splint, you sent them off, we think it's stable, we don't see the patient for 2 weeks, and then they come to see us and now they've been dislocated for 2 weeks, their joint is now super stiff, we got to take it to OR. As opposed to sometimes if it's just a classic PIP dislocation that's consistently unstable, we could probably use pin fixation and they could be moving again, or at least the other joints in the hand could be moving again to get them going. And the severity of the injury is really determined by the joint. So it's kind of like almost The MCP and the PIP, those are the ones that we are the most, well, the PIP we kind of are used to, because if you count kind of like a volar plate avulsion fractures, but the MCP really are tough joints to reduce. And the reason is because you have this noose effect. So you can see that when you have a dislocation at the MCP, you really get that metacarpal head, which is very wide, pushes outwards traditionally, and it gets suspended in between your structures that surround it. So your natatory ligament, your superficial transverse metacarpal ligament, and then your flexor tendons and the lumbricals. And the problem with this is if you pull on it, you think logically, okay, I see it, it's dorsally dislocated, I'm going to put longitudinal traction. But what ends up happening is you actually pull on your flexor tendons and it gets this noose effect and you'll never be able to reduce it. And so these are traditionally taken care of in the emergency room or in the OR, but they need to be done. We need to release the A1 pulley. We have to pull out the tendons and then reduce it at that point. Or what you can do is if they're really relaxed, and I get this often where they say, you know, they gave a lot of propofol and we really tried to relax the patient, but it's really a relaxation of the muscles. So if you do like a very proximal nerve block, you get anesthesia to do your block, and then you kind of you flex the wrist to relax all the flexor tendons, and then you try reducing it, it will be more successful, because what you're doing is you're actually releasing the traction on the flexor tendons, and so you're really relaxing that noose effect, and you can put it right back into place. For UCL injuries, which are very commonly seen, for the purposes of the emerge, it's really, you know, you could get them to do a stress x-ray, which is something that I think is not commonly used, but I think is very valuable, especially if you're trying to figure out if it's a displaced fragment. So what I do is I get the patient, I literally send them for the traditional x-rays, but then I also get them to do this motion, because what you're doing is you're actually pushing on the UCL and you're straining it. And this should show that if there's any bony fragment in place, for example. Otherwise, you know, the classic examination, you get them to do it you check for deviation, both in neutral and in 30 degrees of flexion, because there's the proper and the accessory UCLs. If they're completely gone, and you have a Stenner lesion, that's because what happens is you see here, the UCL comes out and goes above the adductor aponeurosis. That's not going to heal regardless of the splint. So we have to take that to surgery. But for your purposes, you put them into a thumb spica and you send them to clinic, and then we would order other exams. So if you were in a family practice, for example, and you saw this and you wanted to expedite the procedure, you could always order an ultrasound or an MRI to basically see if this Stenner lesion exists, because if it does, it's a surgical diagnosis. So thumb spica to clinic. For PIP joint, now these are very complex. So traditionally for volar plate avulsion fractures, which I feel like we're seeing more and more of these days, we always saw them, but I just don't know why, but there's been like an influx of them. There's two schools of thought. The first school of thought is that if it's a small volar plate avulsion fracture, so it's just a chip fracture, then what we do is you can either do a buddy tape. So that's school of thumb number one. So you buddy tape the next finger together and you get the patient to move, or off sports for 4 weeks. Or what you can do is you could do an extension blocking splint and you send them to occupational therapy. For the purposes of the emergency room, it's way easier to do buddy taping, especially if you're 100% convinced it's a volar plate avulsion fracture. You buddy tape the patient, you send the consult to us, we'll see the patient and follow up one time, probably 3 weeks down the line, just to make sure things are okay, unless you think it's a little bit more than an avulsion fracture. And that's where we start getting into a little bit of trouble, because that's when you get into the fracture dislocation of the PIP. And for us, for our purposes, the way we treat these is based on how much of the joint is gone. But for your purpose, the truth is all you want to do is you want to put it in an extension blocking splint. Let us know that there's this bad PIP fracture dislocation, and then we got to take that to surgery. So that's very important. Another thing that is when you get a dislocation at the PIP, the best way of thinking about it is the direction at which it dislocates means that the structure that's on the other side has been torn. So if you have a dorsal dislocation, which is the most common, what's the structure that would be traditionally cut or avulsed is the volar plate. Versus if it's a volar dislocation, which I saw the other day for the first time in a long time, it would be your central slip posteriorly. So you have to think about this, especially when it comes to your splinting procedure. So if you have a dorsal dislocation, you reduce it and then you think, okay, it's the volar plate, so I could treat it as a volar plate avulsion, but complete. So you want to put a dorsal blocking splint. Versus if it's the other way and it's the central slip, you want to make sure they're in we would put them in a boutonnieres type splint, but you could just put them in a volar slab and they'll be seen in the clinic. For DIPs, it's the traditional, what we're going to talk about is the mallet finger. So the one thing about the mallet fingers, everyone almost knows how to treat them. You put them in a hyperextension splint, but you really have to make sure they're in a hyperextension splint at the DIP, because what happens is sometimes you put them in just a traditional finger splint, they're in neutral, and that doesn't really help their cause, especially if they are seen 1 to 2 weeks later. Because our treatment is 6 weeks of pure hyperextension splinting with OT. But if you actually spend the time and put them into a good hyperextension with your malleable splint, even send them for an x-ray with it on to show that the bony fragments are coming together, that is going to save the patient 1 to 2 weeks of overall healing time, which is very important for them. If it's an open mallet, well, that's something that we would see, because we would do almost like a dermatotenodesis. So we would close the skin while taking the extensor tendon with it so that we get it into that hyperextension. And if there's no bony fragment and they're still droopy, they still have lag at the DIP, you still treat them as if it's a mallet finger, because it is a mallet finger, but it's a non-bony mallet. Other situations that are important, CMC dislocations, CT scan. Any carpal bone fracture, CT scan. If you're suspecting a scaphoid fracture in an adult, just get a CT scan. It's going to help you out. Because what ends up happening is they get the x-ray, the x-ray is normal, they have snuff box tenderness, they come to see us, we do the x-ray 2 weeks later, we're still not sure, they still have tenderness, they get a CT scan anyway. So what you can do is, especially if it's a high impact, if it's high energy impact, you just get the CT scan and it really tells you what's going on. Perilunate dislocations, we need to be called, because that has median nerve compromise. So we do our classic Tavernier method. I'm not going to go into it, but it's very important that you call us to get a CT scan before, so we see what's going on, and that we make sure that they're properly reduced. But like I was saying, it's really, sometimes I get called for, like if you have a hamate fracture that you see on an x-ray, like I get a CT scan, because that has a lot of implications as to what else is going on, because it's hard to fracture these carpal bones, and there's the treatment for them is very intricate as well. Okay, before I move to, I know I don't have that much time left, but before I move to the face, is there any questions?
Yeah, I got a 3 questions here. So the first from Dr. Nemeth says pet peeve of his.
I see it.
Do you see it? Yeah.
Well,
okay.
I'll tell you why. Because if you tell me that it's a concert pianist who has a fracture, has a boxer's fracture, and it impacts their profession, they're much more likely to want to undergo a surgical treatment to be able to change their outcome. Versus if it's someone that does not use their hands, or is let's say they're right-handed and it's their left D5, or it's a finger that really has no impact in terms of function, then we're a lot less likely to see them. It's basically just for us in terms of follow-up, as opposed to, yes, everyone should get the standard of care, of course, but you know how it is. Like, there's a reason why the hockey players get operated on more frequently than the other patients. It's not only because they're hockey players, but it's because it's a part of their but it's the truth. Like, it's not like, when we see patients in the clinic, we really have to figure out what's the best thing for them, because we don't have as much resources as we want, right? And if we were able to have a hand clinic every day and we had unlimited OR time, it would be awesome to provide everyone with the same service, basically.
Yeah, great. Okay.
Can you eliminate scaphoid fracture on CT, or would you splint if negative and still tender? So that's a great question. If I had a patient that was very classically tender at the scaphoid, like at the snuff box, and I sent them for a CT scan and it was no fracture, but they were extremely tender, I would still splint them and I'd have them follow up in clinic, because we have to treat the patient and not necessarily the scan. And I don't think that's there. Exactly. There is a risk of the next point. It's not always a guarantee that you'll pick up 100% of fractures, but if it's an unclear mechanism, like unless it's a fouche, then yeah. But like sometimes what we get the patient comes in, they were in a car accident, they have snuff box tenderness. We did an X-ray. X-ray was normal, and then we put them in a splint and send them off. That's fine. But if they're exquisitely tender and you see even a slight doubt of a fracture on the scaphoid, I would send them for CT scan. And the worst case scenario is we send them again for another CT scan. We barely use MRIs these days. For the only time we really use MRIs is even if we know that there's AVN, we still send them for a CT scan first, and that's really a resource thing. Although MRI is better for AVN than avascular necrosis than CT scan is, and sometimes we send it for follow-up, basically. So I know it's kind of like a little bit of both, but my whole point is if it's a high impact injury, CT scan really does show a lot of things that you would not normally see on an X-ray, and it does affect treatment as well.
There was also a comment I received, just if you wouldn't mind just showing us your technique for the radial block again, just, you know, what you kind of did a physical.
Yeah, so basically for the radial, so let's say I have anything on the radial on the radial distribution. You know where it is, right? It comes out here. It's usually 5 centimeters on the radial side. It comes out and it branches. And there's usually 3 branches. So it goes 2 here, and then basically it's like 1 here. I'm doing myself, and 2 here. So what I do is I introduce the needle usually on this side, and I stay subcutaneous, and I just go all the way along, and I just create a bleb the entire way along, to be able to get all the distribution. That's what I do for my radial blocks. They're the least likely to work on the first go, just because of the actual variation, and it's not like it's always in the same spot like the ulnar nerve and the radial and the median nerve. Okay,
great, thank you.
Okay, so this is my 1-slide facial trauma. This is what I give even to the R1s for their teaching. So the first thing is orbital floors. We have to assess for entrapment. If there's really nothing on exam and they have full range of motion, so you'd really see that right when you have to think it's the inferior rectus that would get caught in the fracture. It is more rare in adults, just because usually in peds we see that green stick pattern fracture. So they come down like this and it gets cut inside and then it comes back up. And so it's really hard to get these, even when you go to surgery, it takes a long time to get the inferior rectus out. But when you do get the patient to look up, you will see they'll either complain of diplopia, or you will see that they're unable to really look up. And of course, you're going to say, well, it's extremely hard to do in a patient that has huge periorbital ecchymosis. And I agree with you. That's why ophthalmology always needs to be involved. They're the ones that are supposed to tell us if there's any signs of entrapment. But you know, sometimes you get these patients that walk in, they were punched to the face maybe a week ago, and they have a orbital floor fracture. So you send them for a CT scan, and they have complete full range of motion. It's not something that needs to be urgently. We'll still see it, but it's not something that needs to be like urgent. For mandible, if there's teeth in line with the fracture, so this is the one part about plastics being on face call, is that we have to get dentistry, not like OMF that will be able to do it themselves. We always send the patient with a Moxie clav. Clinda is just, I don't like it personally, and you need to get that anaerobic coverage with Paradex mouthwash 4 times a day, just to clean the area. And I'll show you a really cool technique for bridle wiring after. Hopefully I get to it. I have to speed it up. I have 3 minutes left. Nasal bone. Clinic if it's non-displaced. If it's a reduction, I actually don't do any sedation anymore. I find it's more painful than the actual reduction itself. I literally just tell them, take a deep breath, and I push on it. And always assess for septal hematoma. Any orbital rim fractures always require orthopedics. No, ophthalmology. Frontal sinus pneumocephalus, neurosurgery. Temporal bone is ENT. Lafort fractures, those multiple things. And then maxillary sinus fractures, we just send them on sinus precautions. We don't want them to blow out their sinus. When it comes to lacerations, make sure that if there's tear ducts or the lid, you get ophthalmology to come assess as well for face lacerations. So these are this is one I just saw recently in the emergency room. So for tips when you're doing your repairs, you want to make sure, I always use, the first thing I do is when I have to make sure I see what I see. So I have to use something that's going to clean well. I use hydrogen peroxide because it really, and I'll show you later, it really gets rid of dried blood very, very well. It could be a little bit painful to the patient. So sometimes doing a little bit of pre-anesthesia, depending on where it is, you don't want to do that on the lips because you really want to make sure you have good approximation. I use iodine for my preps. making use of your infra and supraorbital blocks. So how you do those is it's all mid-pupillary line. So I inject through them intraorally. I go up and I just follow where my needle is going to about here. And that's where I inject. That's the infraorbital nerve. And the mental nerve, this is the same mid-pupillary line 1 centimeter down, or the second premolar. But no one remembers second premolar. So if you're doing this in the emergency room, you want to follow the mid-pupillary line. And the best part about that is you don't get really disruption of your important landmarks. It might take a little bit longer to get your anesthesia, but it's important to do. You want to use small sutures, figure of 8 for the muscle. Make sure you mark the vermilion. And you want to, I poke it with a needle after I get anesthesia, or I use methylene blue, or I mark it preoperatively. And then one thing that you want to do a soft dye with no seeds, because seeds could actually get into your laceration and that could cause infection later on. And one thing I actually saw one of the peds emerge staff do, I thought it was genius, is they actually use their glue, but they only put a tiny drop on the actual knots so that they don't come undone that well, that easily. And it was pretty amazing, and it really worked, especially in the kid who was at severe intellectual disability, and they were really a difficult patient, and it was really a great way of maintaining our repair. This is a really nice table that I created, and it's just a way for me to think about certain things. So I know it doesn't really have anything to do with anything now, but if you guys want to take a look at it later. Quickly, for fingertips, for paronychia, I incise the lateral fold. I get them to soak in 50% iodine, 50% warm saline. Always rule out herpetic willow. You don't want to cut into that. I saw one the other week, and it was quite interesting actually. And they almost did they almost cut into it in the community, but then they sent it to us remembering that they don't. So it was really good. For a phelon, if you're going to use a mid-lateral incision like I do, you always want to think about what's the pressure point of the hand. So for example, like you're going to rest, you don't use the radial side of your D5. You do use the radial side of your D2. So you'd always want to cut on the other side that you don't necessarily need. For nail bed injuries, again, if it's a subungual hematoma, as soon as you drain it, it becomes an open fracture by definition. So you want to give antibiotics. And then you want to remove the nail plate and repair with 6-0. Replant, we're not going to go into. Flexor Tino, the whole point here is that you want to give them 48 hours of antibiotics before we really do any surgical intervention for the most part, unless they have approximately extending signs of infection, erythema going on, like we had one the other weekend, all the way to the elbow. And so that's something completely different, but most of the time we usually let it go with 48 hours of antibiotics, broad spectrum. They very rarely happens on the extensor surface. So it's really a flexor because the flexors have that tenosynovitis, tenosynovium. Septic arthritis, if you're ever gonna, so it's almost impossible to actually get fluid from these small joints, but if you're actually gonna do wrist or whatever, you always wanna make sure you send for crystals. The usual workup for a septic arthritis, I'm sure you guys go into that quite a bit, but I wanna get into some of the more interesting things. I said this last time, it's very important. If you have an extensor tendon laceration at the wrist, you always wanna make sure that there's an extensor retinaculum that you have to re-repair. And we use figure of 8 sutures for everything dorsally. So anything on the dorsal surface is figure of 8. You really could use any suture material, even Vicryl in some centers they use. Here we use a permanent stitch, but that's just us. And you want to repair the extensor retinaculum. I want to get into.
You don't have to
this
rush
is something that we
don't worry. It's okay. Don't feel like you need to rush.
Oh no, but I want to get into some of the cases I think are really good examples of what when some of this stuff is important.
Sure, but this is
when you
great,
have burns,
so don't, yeah.
When you have burns, I know this is tough because we're not a burn center, even though we probably should be. But when you have burns, you always want to call us or call the burn center if in doubt, especially with chemical burns, because chemical burns, some of them are very, very, very tricky. And we get McGill lab students. I've seen this. I've been in the emergency room where there's been a McGill lab student that will spill phenol on themselves, or they'll spill something, and it's just what do you do if you irrigate some chemicals? If you irrigate it with saline, could actually cause a worse reaction. Or if you think, oh, it's an acid, putting a base, all these things, there is antidotes for certain things. So it's important you either speak to a burn surgeon or you speak to the poison control. And the indications for patient selection for transfer to a burn center, these are the classic textbook ones. The way I think about it is 3rd-degree burns, hands, anything important. So genitalia, hands, feet, face, electrical burns need cardiac monitoring. You have to watch out for rhabdomyolysis in these patients. You need to make sure that these trauma patients with a concomitant burn or vice versa, you always got to look out for other signs of burn. So some electrical burns, they'll have a small entry wound and they'll have an exit wound, and you'll think, oh, it's not that big of a deal. But what actually happens is on the inside, there could be a ton of myonecrosis. They could have changes to their myocardium. And that we think of an electrical burn almost like a cardiac contusion. So really could be on the huge spectrum of things. So they need cardiac monitoring as well as a full set of labs and monitoring as well. And then the classic rehydration protocols. So for burns, we get asked often, what about the blisters? We always debride the blisters, especially if they're going to come to see us, because if you debride the blisters, first of all, we get a really good idea of what the burns look like when they come to see us in the clinic, because burns traditionally take almost 3 to 4 days to declare themselves if you don't have any advanced imaging or like a near infrared or Doppler imaging. So we always give tetanus, blister, irrigation. We do a silver dressing for 5 days or polybacterial Q2. We tell the patient, drink and have a high protein diet. When you're immediately examining, any second degree burn will have blisters because it goes through the dermis. If it's a partial thickness, superficial second degree, you'll have sensation, you'll have some of the hair follicles will still be there. If it's a second degree deep, you might lose that. It might look a bit more white. It might be a bit, I wouldn't say leathery, but you could tell there's a difference between a second degree, superficial and deep. One's red, one's a bit more white, one's less sensate. And then third degree is really, leathery. So here are some of the cases. I promise it'll be 2 more minutes. So this is an example, like I was saying. So this patient presented to the emergency room. This is a classic flexor tenosynovitis. I saw this, I said, okay, wow, 48 hours of antibiotics for this. Really, at this point, this has probably been going on for about a week now. So I made the decision in conjunction with my team and the staff that we were going to open this. And when we opened it, it was just a ton of pus that came out, and he was very lucky because it really didn't spread proximally. It was very well isolated to the finger. So we would just release the A1 pulley. I made an incision. Oh, you don't see sorry, I'm like using my pointer, but you don't see it. But I made an incision at the A1 pulley, and I made an incision distally so that when you irrigate, it's able to come all the way through the tendon sheath. So here's an example of a mandible fracture, symphyseal mandible. Every time he smiled, he ended up having this gaping wound in his mandible. And these patients have pain, but they have pain because the fracture is not able to maintain reduced. So what I did is I used dental wire, 26 gauge dental wire, and I did a bridle wire basically. So I went 2 and 2 teeth. You have to make sure they're not loose. And all I did is I wrapped them around. I did mental nerve blocks bilaterally. And then I just do this to kind of keep the fragments together. And his pain requirements shot down to almost nothing. And his reduction in surgery was way easier because these bridle wires are on. So something to think about if you're in the community. Very easy to do. So, this is an example. This patient came. I was on replant call. And so important in this situation, the first and most important thing is you see this skin bridge here. Do not remove this. So some people say, oh, and it's really nothing. It's just a little bit of skin. It's already cut off, but it actually turned out that this was a very important dorsal vein, and we didn't have to, there was no other veins. So if we didn't keep this finger might not have survived when we put it back together. So you take an x-ray of this, you take an x-ray of this, and then you call a replant center and they'll tell you what to do. So we sent the entire hand in a moist gauze submerged in a bag of ice to keep it cool. I don't know if any of you guys were there when I did this the other day, maybe a few months ago in the emergency room.
I was there.
And it's like these situations, like a lot of times I get called to things and it's always interesting, but this is an example of where your regional blocks make a huge difference. Because like, how else are you going to give proper anesthesia to get this out? You could give propofol, but you're not really getting rid of that sensation. So I did almost a complete wrist block for him. I don't think I went ulnar. And then what we did, it was really funny, is we called housekeeping and we actually got a screwdriver to unscrew instead of avulsing the structures. So we screwed it out and put a little bit of traction. And again, we get neurovascular exam pre and post and prepare and, warn the patient that if there's a massive bleed or it went through the arch that you would likely need to go to surgery. And there's the screw. In this example, so I got a call from an outside center. So you have basically two choices. If you're at an outside center, you could either repair the extensor tendons and then close the skin, or you could just close the skin and put them into a volar slab, right? So for extensor tendons, we put them in a volar slab, and for extensor and for flexor tendons, you want to put them in a dorsal slab because you don't want the patient to hyperextend for the flexors, it will pull, or in the extensors, you don't want to hyperflex because it will also pull. And the other things is you want to make sure you always irrigate, you always give antibiotics, and you always give tetanus. This example is very important because here, let's just say this actually had a fracture as well, but let's say it didn't. Right here is your central slip. And this often goes unnoticed because the patient will still maintain extension because the lateral bands will continue going and you'll have your terminal tendon. So at first you'll be like this, but over time he's going to slowly develop a boutonniere deformity. So it's very important that you always watch out over the PIP joints for central slip avulsions and central slip lacerations to repair them. This is a patient I saw at the MGH. He had a garage door fell in his face. And the reason that I show this all the time is because, you know, a lot of people, when they see this, the first thing they're like, you know, what do I do? First airway, and, you know, you do your ATLS protocols, of course. But the one thing I want to highlight is the importance of using hydrogen peroxide. Look at the difference in the wound between here, you can barely see what's going on, versus here after just, you know, simple hydrogen peroxide. I do irrigation, then I put iodine prep, and then I clean off the iodine. And you can see that it's full thickness down underneath SMAS. So here are the nerves to the muscles. So in the face, the nerves that supply the musculature always run underneath the muscle bellies. So you can tell that this is quite a deep laceration. And there's one other structure that's extremely important to worry about when they have deep lacerations like this, is Stenson's duct. So you always want to make sure that if Stenson's duct is involved, that you call ENT to come and to fix it, because they can end up with severe problems for the rest of their life. And I just repaired this. Yes.
I'm actually curious to see, how did you anesthetize this patient? Just soup run in for nerve block?
For him, what I did is I did percutaneous. So I didn't go anywhere. I just went right here, right in the mid-pupillary line, and I injected a little bit right here at first, just to get that infraorbital distribution. And then following that, just enough to be able to clean. And then what I do for these patients is I don't want to give them tons of lidocaine, and you actually don't need tons of lidocaine. So what I sometimes do is I'll use the sterile NS, and I'll dilute my 10 cc's of Lido 1% with epi into 20 cc's. And then that way I'm able to really irrigate, almost do like a field irrigation. And I just irrigate always through the incision because it's less painful. And I just go all the way around. I mean, I think with him, I had to give a little bit of ketamine he was very, very anxious, but it really wasn't that painful once I did my little infraorbital nerve block here. And then I kind of, using that distribution, I started from here. You don't see my thing, sorry. But I do my infraorbital block right underneath the mid-pupillary line. And then I kind of go from a stepwise approach. So I started proximally at the nose, and then I went distally as he was already anesthetized, right? Because from the infraorbital block. So it really wasn't that painful for him. Just following where you anesthetize and using that path is what I did. And then I repaired it in 2 layers. I repaired the muscle, 3 layers. I repaired the muscle layer, then I repaired the dermis, and then I repaired the skin. But then he came to clinic. I think this is an amazing repair. And he came to clinic. He was a little upset about his nostril here, but I mean, I didn't know how else to position it after. So well, that's it.
Quick question, Tyler. When you do use peroxide to get rid of the scabs and all the dry blood, do you stay away from the wound, or there's no issue with that?
No, there's some evidence that says that it could cause a delay in reepithelialization. However, honestly, the thing is I'm using it first, and then I irrigate the wound out. So it's not like I'm using it intra-wound, but there are a lot of surgeons that I work with that will still irrigate their surgical sites with peroxide. So I really like peroxide, and a lot of the surgeons do too, because you're not scraping and causing further shearing damage to the skin, trying like for an hour to get rid of everything using just saline.
All right, thanks.
I had a question just about that slide where you had the patient with the nearly completely amputated finger, and so I guess when you're sending for X-ray, like, are you just telling them to be very careful and like don't drop your finger or something, like, so because you say you X-ray the finger and you also X-ray that? Okay.
You always need to X-ray the hand and the part, always, every time, because I remember once I was an R1 and I had a replant case, and I saw that there was the finger, the loose finger, and I saw the hand like this. And so what I did is I x-rayed the hand, and the hand looked like it was a perfect replant patient. But then I called the replant center and they said, okay, can you x-ray the distal part? And I x-rayed the distal part and it was completely smashed. Like there was like almost no bony stock left. So they said it's not a replant candidate. So it's important to see both parts.
Okay, thanks. All right, any other questions?
Sorry, I went a little bit over time there.
No, every time you present, it's always great. So we permit it. All right. So,
one thing about what we do is it's very like, there's one thing about plastics is the evidence is not amazing for everything, but there's certain things, and so a lot of it is passed down almost like anecdotal. So like hydrogen peroxide, for example, it just really, it makes life so much easier. So it's not like I could tell you with certainty that it won't change anything, but it's a trauma patient. So they'll heal as best as they could heal, and we could always take them for revision later on if they need it.
Awesome. All right. Well, thanks so much, Tyler. That was great.
Thanks, guys.
And yeah, we'll see you around.
Perfect.
Okay. So that's the end of
guys.
And RPC.
And the beginning of Christmas holidays, almost.
Oh yeah, yeah. That's the holiday season. So very exciting. All right. So I guess for those of you going to RPC, we'll see you at 12:30. And yeah, have a great rest of your day and week.
We'll be back on January 5th for interactive, and then the next formal rounds are the week after, January 12th, I believe. See you guys there.
Very exciting. Okay, later.